don't miss it. So I need you to watch and listen to this video till the very end, because they are very critical key areas or key concepts that I am going to discuss about that most of you are not aware of. So do not miss any portion of this presentation. Otherwise, you are not going to be competent or to master endometriosis mapping for the rest of your life. So this is just a comprehensive guide to documenting deep infiltrating lesions in endometriosis. So this is my introduction. The objectives of this presentation are, by the end of this presentation, participants should be able to understand the purpose of endometriosis mapping. This is very critical. You must be able to perform a systematic ultrasound examination, apply the IDEA, which is the International Deep Endometriosis Analysis Approach. Did you know about this? Just to be honest, guys, are you aware of what that idea is? The International Deep Endometriosis Analysis Approach. How is it done? So you must also recognize sonographic features of deep infiltrating endometriosis, which is the dye. Dye. Have you ever heard about dye? Or you've been scanning for so many years. Have you ever heard about dye? So in this presentation, you are going to understand what dye is, which is deep infiltrating endometriosis. So you must be in a position also after to produce a structured ultrasound report when you are reporting a case of endometriosis. So by definition, what is endometriosis? Endometriosis is the presence of endometrial-like glands and stroma outside the uterine cavity. It is a chronic inflammatory condition that can cause pelvic pain, dysmenorrhea, dyspareunia, infertility, bowel and urinary symptoms. Approximately 1 in 10 women of reproductive age are affected by endometriosis. So you see how so widespread it is. So now let's discuss what is endometrial mapping. So most of you have been wondering, what is this mapping all about? So you can see here, that's the region of the pelvis, and you can see the different compartments that I've put up. So when I'm mapping, you're sort of localizing the endometriosis. Where is it? So endometriosis mapping is a systematic ultrasound examination used to identify, localize, and document endometriotic lesions before surgery. So it's a systematic way that we use now to identify, to localize, and then to document the endometric lesions or tissue that we see or that is found. So what are the objectives of endometrial mapping? So in this presentation, we are supposed to determine the disease extent, to identify bowel involvement. Is bowel involved or not? Detect bladder involvement, assess ovarian disease, evaluate adhesions, and assist surgical planning. So the compartments that are supposed to be evaluated when doing an endometriosis mapping are the anterior compartment, which is the bladder, and the vesical uterine pouch. Then you also have to assess the middle compartment, that is the uterus, the ovaries, and the fallopian tubes, if they are also involved with their endometriotic lesions, which are also there. So in the posterior compartment, you have what is called the uterosacral ligaments. You must check on those. Then you have to have the posterior vaginal fornix. You have to check for deep infiltrating lesions. Then the rectal vaginal septum, you also have to check on that. Then the rectum itself, you have to look around it. And then the rectal sigmoid colon, then the sigmoid colon. You have to assess for any deep infiltrating endometriotic tissue that you can find there. So now let's talk about the patient preparation in endometriosis mapping. So the preparation. Explain the examination to the patient. That's the fundamental and the first thing that you're supposed to do. Don't do things nicodemously when the patients are not aware what is being done to them. So obtain informed consent from the patient. Encourage bladder emptying. Then position patient in the lithotomy position. That's the transvaginal that we're talking about, the transvaginal approach. So use a high frequency transvaginal probe, 5 to 9 megahertz or higher. Then perform a gentle examination due to tenderness. So these patients, some of them, they will be feeling tenderness due to the endometriosis. So it must also be use a gentle examination. So the clinical history of the patient. Ask about the dysmenorrhea, dyspareunia, chronic pelvic pain, dyschezia, dysuria, infertility, or previous surgery. So you have to ask that kind of history or capture that history before and during the examination. So the idea examination protocol. So here is the protocol. So they are basically 4-step idea protocols, that steps that you are supposed to do when you are doing the idea protocol. So the first step for this protocol is you have to check the uterus and the ovaries. Uterus and the ovaries. Then the second step, soft markers, site-specific tenderness, ovarian mobility. You see that? The second step of the protocol, idea examination protocol, is you have to check for markers. Are there any obvious markers of endometriosis? Site-specific tenderness, go there where the patient is saying that this is where the pain is. Then ovarian mobility, check if the ovaries are moving. So the step 3 is a sliding sign. So the ovary has to be to move. The uterus, sorry, it has to move. That is what we call the sliding sign. I will demonstrate that practically. I will check a case for you, then I will demonstrate for that. I'll present on a practical case like that. Then you can see the sliding sign, how it is done, and where it is positive and negative. Step 4, deep infiltrating lesions. Stress using the same sequence in every patient for consistent. So you must check for deep infiltrating lesions. So you have to stress using the same sequence in every patient for consistency. So you must be consistent, must be methodical in the way you do things so that you don't forget other areas or to assess other areas. So the uterus and adenomyosis. So you must assess for the size of the uterus, the position of the uterus, the myometrium, the endometrium. So when you're checking for adenomyosis, check the size of the uterus. Is it enlarged? The normal size, the position, what the position of the uterus, then the myometrium, the heterogeneity, another lesion that you can find there. Then also check the endometrium. How is it distorted? Is it normal position? Is it enlarged? So you have to look into all those aspects. So the sonographic signs of adenomyosis, so is the heterogeneous myometrium, is asymmetrical wall thickening. You can have myometrial cyst, then you got fan-shaped shadowing, then you can have echogenic islands, then indistinct junctional zone, then the translesional vascularity. So you can have translesional vascularity. So these are the fundamental sonographic signs of adenomyosis. I have been showing you some signs of adenomyosis when we're doing our daily quiz sessions. I will also show you the images of how adenomyosis appears, like different types, different appearances. Then you appreciate that. I will share that one with you in the other slide. So I am saying the sonographic sign of adenomyosis. Did you know about this? Heterogeneous myometrium, asymmetrical wall thickening, myometrial cyst, fan-shaped shadowing, echogenic islands, then indistinct junctional zone or the translesional vascularity that should be present. Okay, so now we have to assess the ovaries, ovarian assessment. So this is still part of endometriosis mapping. So you have to evaluate the size of the ovaries, the mobility of the ovaries, the follicles, and the cysts. Evaluate the size of the ovaries, the mobility, the follicles, and the cyst. So the endometrioma features. So this is an endometrioma there. So it's a homogeneous low-level echoes, which is called the ground glass appearance that we're always supposed to see. Then with the thick holes, so the holes are thickened, like you can see there. with minimum internal vascularity. So there's no or internal minimum vascularity in the endometrioma itself. So bilateral in up to half of cases. So in most cases or some cases, it can present both ovaries. So you have to check both ovaries for sonography sign of endometriosis. There it is, right and the left side. So differentiate from hemorrhagic cyst, dermoid cyst, and the neoplasm. So you must pay due diligence so that you don't confuse them from a hemorrhagic cyst, a dermoid cyst, or a neoplasm. So be very careful when you're doing an assessment of the ovaries to check for endometriosis so that you don't confuse an endometrioma for a hemorrhagic cyst, a dermoid, or a neoplasm, which is the cancer of the ovary itself. So ovarian motility tests, ovarian motility sign, the kissing ovaries. What is called the when you're saying that the kissing ovaries, saying that the ovaries they just get in contact with each other, so they're bigger. You say that they come into contact with each other. So the technique: apply gentle probe pressure, observe whether ovary moves freely, ovary is fixed, ovary adheres the uterus, ovary adheres the bowel. Fixed ovary suggests adhesions. Kissing ovaries strongly suggests severe endometriosis. So if you have got ovaries that are now enlarged, then they are non-mobile, then you should also think of endometriosis. So you must observe again the ovary. If it moves freely, ovary is it fixed? Ovary adheres to the uterus, or ovary adheres to the bowels. So fixed ovaries suggest adhesions. Kissing ovaries are strongly suggestive of severe endometriosis. Now let's talk about what's called the sliding sign. Do you know about the sliding sign, guys? Have you ever heard about the sliding sign? Do you also check on it when you are assessing for endometriosis? So the positive sliding sign structures they move freely. So the pelvic structures, the uterus, the ovaries, they have to move freely within the peritoneal space. So suggest no significant pouch of Douglas obliteration, no significant pouch of Douglas obliteration. So the negative slide sign, structure fails to slide. So suggests adhesions, obliterated pouch of Douglas, deep infiltrating endometriosis. So we are saying that when the adhesions, when the uterus, for instance, is attached by adhesions to the surrounding pelvic organs, it can't move because it's fixed, stuck. It's like a glue that is holding it in space, so it can't move. So a negative sliding sign is one of the signs that we use to say that this endometriosis, or this negative, this absent endometriosis. So you see, you have to make it a point that you're trying to use the sliding sign as much as possible to exclude endometriosis and also deep infiltrating endometriosis. So you also assess also the anterior compartment, So you have to evaluate the bladder wall, the vesico uterine pouch, and the distal ureters when visible. So you have to check there are nodules there. They have to check. You see, this is the wall of the bladder there. You can see there's a nodule there. So this is endometriosis. So this is deep infiltrating endometriosis. So you can see a nodule there on the base there. That's a nodule there, and the bladder is there. The sonography findings: hypoechoic nodules, irregular wall thickening, then reduced mobility, and then the focal tenderness. So these are the signs of deep infiltrating endometriosis. So you can see these hypoechoic nodules, they deposit there around the bladder, around the vesico uterine pouch, and around the distal ureters. So be very vigilant when you assess for deep infiltrating endometriosis. So now you also have to assess the posterior compartment. The posterior compartments. What do you assess? You see these hypoechoic nodules that we have. These ones, they can be very silent. That you see those ones. It is very easy for you to miss endometriosis, deep infiltrating endometriosis, if you are not so diligent. You see how they appear. Like you see that one around the sigmoid colon there. You can see this area that is hypoechoic there, like a rim. It looks like a mass, like it is. There is a rectal sigmoid cancer there, but it's endometriosis. So assess uterosacral ligaments, the posterior vaginal fornix, the rectal vaginal septum, and the rectum, the sigmoid and the sigmoid colon. So for those hypoechoic nodules, So the typical features of deep infiltrated endometriosis are solid hypoechoic nodules. They with irregular margins. Then they can retraction and then fibrosis, tenderness, and the distortion of the anatomy. So you can see that the anatomy will be distorted, and you are seeing these features. Then you should know that you are dealing with a case of endometriosis. So the features again: solid hypoechoic nodules. So you see, these are the solid hypoechoic nodules that I'm talking about. These are the solid hypoechoic nodules that you are seeing there. They've got irregular margins, so they're infiltrating, and retraction, fibrosis, tendon distortion of anatomy. So bowel endometriosis. So you can also see that endometriosis can infiltrate and affect the bowels. So you can see this deposits in the bowels there. They deposit in the bowels. So you can see on CT, there on MRI. Sorry, you can see endometriosis there. So the common site is the rectal sigmoid colon. That's where mostly you find deep infiltrating endometriosis. The entity will appear like that. So the sonographic features: hypoechoic muscularis lesion, hypoechoic muscularis lesion, irregular thickening with a narrowing of bowel lumen, and then reduced sliding. And then we can have fixed bowel loops. So the loops can also be fixed by the adhesions. So this is how you make an assessment of bowel endometriosis. So the measurements: you should record distance from the anal veg if assessed, then the lesion size, circumferential involvement, depth of invasion. So you know, once you are drilling the bowel, so you must also assess the circumferential involvement. Is it occupying 1/3 of the bowel? Is it affecting 1/4 or the whole bowel? Is it encasing the whole bowel or not? So you have to report on those when you are doing endometriosis mapping. And the depth of invasion, how deep is it? You understand? So uh, initially I said you must also measure the distance from the anal veg. So from the anal veg there, you can then make a measurement to the exact spot where you see an endometric nodule. How far is it? So this is mapping because we are localizing it. So this is the structured reporting. How do you report on endometriosis? So there's suggested report format for you guys. I've just put this one suggest for you. Then you can also alter. This is just a template. So the clinician indication: pelvic pain, dysmenorrhea, infertility, then the uterus, the position, the size, adenomyosis, if it's there, they comment on it, the ovaries, the mobility, endometriosis, they are there, the adhesions, then you're checking on those. So the sliding sign, is it positive, is it negative? This is part of your report. Anterior compartment, talk about the bladder, the vesicular pouch, are they clear from these nodules or not? Then the posterior compartment, guys, you have to talk about check also the uterosacral ligaments and report on that, the rectovaginal septum, the rectum, the rectal sigmoid, and the sigmoid. So just make sure on the report that you're including those to make sure that it's mapped. This is a special type of a report. It's not the normal pelvic ultrasound report that you're talking about. We are now talking about endometriosis mapping. So the report of an endometrial map must show this, and the region that you didn't see, you have to indicate that I couldn't see the rectal sigmoid. I couldn't see the rectum. I couldn't see the sigmoid on ultrasound. You understand? You have to, so that the clinician will know which area has been mapped. If there's need for a CT MRI, you understand? Then they can go for the MRI. So now, the conclusion: no evidence of dye, no evidence of deep infiltrated endometrium. If there is none, if it is there, then you have to report likewise. Mild disease, moderate disease, extensive disease with the bladder or bladder, bowel or bladder involvement. So you have to also then conclude, like, if it is is extensive, is affecting the bladder and the bowels. So you have to take note of that in the endometriosis mapping report, ultrasound report. There's a special type of a report. That's why I make this presentation. So now, the your key takeaways. So it has been a long presentation. So let me give you the key takeaways, and then you can call it home. You can call it a day. So remember these 5 key points. 1, follow a systematic examination protocol every time. 2, Always evaluate ovarian mobility and the sliding sign. 3. Examine the anterior, middle, and posterior compartments. 4. Measure and document every lesion accurately. Then 5. Use a structured report to improve communication and surgical planning. Use a structured report to improve communication and surgical planning. So let me repeat the takeaways again. The takeaway points: follow a systematic examination protocol every time. Always evaluate ovarian mobility and the sliding sign. Don't forget to examine the anterior, the middle, and the posterior compartment. If you don't, you have to tell the referring clinician that I couldn't do this. Then maybe there's a reason for that. Measure, document every lesion accurately and localize it. Use a structured report to improve communication and surgical planning. So don't just make a report haphazard. So with the structure of a format, you can have a template for endometriosis mapping. So those guys who are having maybe using their typing their reports, I urge you that you can make a template for endometriosis mapping, so that every time we're doing an endometriosis mapping, you just edit your report so that it conforms to a certain standard in their format. So this brings us to the end of this exciting presentation. Ladies and gentlemen, I thank you so much for your time, for your resilience, your patience. I encourage you to like and share our videos if you so do like them. Then I also need you to give us an honest feedback if there are areas of improvement or what else we could do differently for you to understand or to master what we are trying to put across. So there are practical sessions. If you are going to follow our practical cases, I'm going to be including the videos, upload some videos, so that you can also see how we do the practicals. Thank you so much. Enjoy the rest of your day ahead. Thank you. Hello, colleagues. How are you doing? I hope that you are doing very well. So in this presentation, let us discuss about an intrauterine contraceptive device. So when someone is having an intrauterine contraceptive device and they start to have lower abdominal pain, the assumption is it could be the IUCD that is causing the pain. So at times, the IUCD will be very much innocent. So in this presentation, I need you to understand the role of ultrasound in evaluating patients with pelvic pain and an IUCD. So you should be in a position to recognize the normal sonographic appearance of an intrauterine contraceptive device, and then also differentiate IUCD related complications from unrelated pelvic pathology. You must also appreciate the importance of avoiding diagnostic bias. So, you don't just rush into conclusions to say. So, the history of this patient is a 32-year-old female. So, it's a para 2. So, she's complaining of severe low abdominal pain for 5 days with intermittent pelvic cramps. Then she has mild spotting and pain worse during intercourse. She has no fever and no symptoms of urinary tract related. Then the copper IUCD was inserted 82 months earlier. So that's the brief history of the patient in question that we have today. So the initial suspicion from the referring clinician was that it could be an inflamed intrauterine contraceptive device, or is malpositioned, or probably it's just pelvic inflammatory disease or an embedded IUCD. So the patient was requested for removal. She requested for removal of the IUCD because from the discussion they had with the doctor, she thought that was could be the culprit. So on ultrasound, as you can see, I used trans-abdominal. It was good enough, so I didn't have any need to show you the images that I later did, or to demonstrate the ovaries. So here you can clearly see, or here you can clearly see here the IUCD there. You can see it nicely there, and then you can appreciate that the surrounding areas, they are looking very okay. So the first thing that you're supposed to do is identify the uterus, then also the size, also the contour of the uterus. You have to make sure that the contour of the uterus is smooth and there are no other confoundings. So the uterus in this case looks homogeneous. There are no fibroids that I saw definitely, and I didn't see any sonographic sign of adenomyosis. So the other thing that you're supposed to do is to assess the endometrium, then the fluid, if there are fluid anyway, or there are any retained products, endometrial masses. So those are some of the things that you ought to make peace with. So the assessment of the IUCD position is very pertinent, very critical. As you can see there, you must check for the fundal position, then the arms of the IUCD. So let me show you the arms of the IUC that they are fully extended. So they need the stem is centered. So this is the stem. So these are the arms. So you can see these are the arms. Let me show you the arms. So what we have here, these are the arms of the IUCD. You can see they are well fully extended there. So that's the stem of the IUCD. So it should be centered. So you can see that it's symmetrical. It's centered in the endometrium, as you can appreciate there. So the entire device within the endometrium, so you can see that the entire device is located within the endometrial cavity, as you can appreciate there. So I can't see any sonographic evidence of embedment. So like this, look at this picture there. That one is this one is embedded. That's an abnormally positioned intrauterine contraceptive device. So there's a difference. There's no sonographic sign of perforation as I've seen from here. And also, I did not see any photograph sign of rotation or any migration, as you can appreciate from this echogenic IUCD. So on ultrasound, basically you have to understand the how it appear like. So it should be bright, as you can see, and echogenic stem. So on transversation, again, you must appreciate a small dot that is echogenic. So it should be symmetrically positioned, as I've alluded to. So you also have to demonstrate to show the cervix, and if there's nothing in the cervix as well, then if you can appreciate the ovaries, the normal follicles, the blood flow in the ovaries as well, if to check if there's no torsion, because if there's no pain, you if there's pain, then you should consider other factors if the IUCD is in normal position. So you also have to assess the adnexia for possible masses that you can see in the adnexal regions, and no sonographic sign of tubal ovarian abscess. If there is any hydrosalpinx, ectopic pregnancies, is also you have to make peace with those. So you must also appreciate the back of the uterus, the part of Douglas, if there's no free flow in the POD or any complex collections, pass. So those are the things that you should look into. So in this case, or in my case, there was no evidence of an IUCD causing the symptoms whatsoever, unless maybe otherwise you saw them, but I tried my best, I couldn't. So now, what could be the differentials in case that the IUCD is in position, like in my case? So the differential can be early pelvic inflammatory disease that cannot be maybe not be so invisible on ultrasound, or ovulation pain, which is called mitochemies, can also cause pelvic discomfort or pain. So endometriosis can also be another factor. Then, unfortunately, from this video only on transabdominal, it could be difficult for you to visualize deep-seated endometriosis. Then you can also miss that one. So small hemorrhagic ovarian cyst can also cause abdominal pain or low abdominal pain. So gastrointestinal complications can also cause the pain. So in this case, that could possibly explain it, because you can see there's some bowel gas there. So this is some bowel gas that you can see here, which is casting this dead shadow there. So it could probably be due to bowel-related issues. So urinary pathology can also cause low abdominal pain, or it can be musculoskeletal related. So my advice to you, ladies and gentlemen, is you must avoid bias. So many clinicians immediately blame the IUCD for a crime that it never committed. So when a patient presents with pelvic pain, however, a normal IUCD does not immediately automatically mean it is responsible for the symptoms. So ultrasound, the role of ultrasound now in the evaluation of an IUCD should now evaluate the uterus, the ovaries, the adnexia, the cervix, the cow district, and the urinary bladder for any other pathology that might be causing the problem before concluding that the IUCD is the cause. So in general, we should not always blame things. You must also look at the merits of certain things. So the IUCD is one of the safest long-acting reversible contraceptive method. So if it is correctly positioned, like in this case, it really causes severe pain after the initial insertion period. It can cause persistent pain, usually suggests another pelvic pathology. So if you see that there's persistent pain, it could be something else. It could also be the one causing the infection. So it can be rejected by the body. So those are some of the things that you have to make peace with and understand when you are assessing the PID. So ultrasound plays a crucial role in confirming correct placement and also including complications. So you must know that when these patients comes to your department, the ultrasound that you're using is very valuable in the assessment of an IUCD. So some of the complications that arise from the insertion of an IUCD can be malpositioning, that's I've discussed about, or a low-lying IUCD, then impediment arm within the myometrium, like what you saw in this image there. So it's embedded there, and also perforation. You can also perforate and it go outside there, the mass of the myometrium of the uterus. So and it can also be expelled via the cervix expulsion. Then it can also cause pelvic inflammatory disease. So that would be PID. So thickened uterus, free fluid, and hyperemia are associated with pelvic inflammatory disease or the infection that can be induced by these IUCDs. So pregnancy, gestational sick despite IUCD. So these are some of the challenges that someone can still get pregnant despite them having the IUCD. So those are some of the challenges. So now when you're writing the report, you must indicate that there's no sonographic evidence of malpositioning, impediment, perforation, inflammation, or pelvic inflammatory disease. So those ones you should always write them in your report. So now the learning points in this case are always assess IUCD location systematically. So you have this systematic way of doing things and just not blaming the IUCD for crimes that it never committed. So in normal position, IUCD is unlikely to be the cause of chronic pain, and ultrasound should exclude the alternative causes before recommending IUCD removal. So you must also correlate imaging findings with the clinical examination laboratory results. You must avoid bias, so do not attribute symptoms to the IUCD without objective evidence. So we need objective evidence before we can say that the IUCD is the culprit or the cause of pain that the patient will be experiencing. So I think this is making a lot of sense. So I really had to include this case under my discussion because it's not always the case that if there's pain, it is always attributed to an intrauterine contraceptive device. But the knowledge and the history that for you that know that it is there gives us a lot of leeways to navigate through. So we are navigating from multiple angles to see, is it the cause? Can it be the culprit or it's not or something else? So ladies and gentlemen, next time when you see a patient with an intrauterine contracture, don't exclusively exclude that as the cause of pain. It could be, in most cases, could be the cause of pain, malpositioning, inflammation which are induced by these IUCDs. So I thank you so much for your time. I hope you are learning, and I also appreciate your presence in the channel. I also take your comments seriously. Please do give us constructive criticism so that we grow. We also reach the bigger audience. We need a bigger international audience that is coming to harmonize our practice, to improve our practice, also we need to learn from them. Thank you very much. Enjoy the rest of your day. Welcome, colleagues. So in this presentation, I am going to discuss about what is called the misleading shadows. So when you're doing your ultrasound, there is what we call the misleading shadows. Have you ever heard about the misleading shadows? Oh, it's your first time. If it's your first time, I am going to take you through. I need you to listen and you get to appreciate and understand what these misleading shadows are when you're doing an ultrasound scan and the illusions that arise because of the misleading shadows. So differentiating solid ovarian masses from pendangular fibroids with Doppler. So a comprehensive ultrasound presentation for sonographers, radiologists, and gynecologists. This is quite comprehensive, ladies and gentlemen. Quite comprehensive. So I need you to listen till the very end. Do not miss any portion of this presentation, please. Otherwise, you are going to have a problem with your diagnosis and giving misrepresentations. So now, the misleading shadows. Differentiating solid masses from pendangular fibro using color Doppler. So you can see this is color Doppler. You already know color Doppler and how to use it. I hope so. If not, I am sorry. I need you to work on that. So you can see the uterus there, the ovaries there. So this is a B mode, then color Doppler. So by the end of this presentation, participants should be able to understand why pendangular fibroids mimic ovarian tumors. You must understand the difference there. So identify grayscale clues, use Doppler correctly, and then you must recognize the bridging vessel sign and also apply a systematic diagnostic approach and avoid unnecessary surgery. So, if you are going to write these dubious reports, it will lead to a lot of unnecessary surgeries, which are not called for. So, a pendangular fibroid, subserosal fibroid, projects away from the uterus. I hope you know I've explained about the different types of fibroids before, but it's the one that projects away from the uterus. So sometimes the connecting stalk is extremely thin. The ipsilateral ovary cannot be identified. The lesion lies within the adnexia. So at times the pendangular fibroid can mask or obscure this ovary which is on its side, and it becomes very difficult to visualize. So the examiner might therefore conclude that a solid is a solid ovarian mass. Because it's obscured, you can't see it because of the pendangular fibroid. So you think that the fibroid itself is an ovarian mass instead of pendangular uterine fibroid. So this mistake can completely alter the patient management. It really alters the management of the patient. So now, what are the clinical consequences of this mishap? So misdiagnosis may lead to unnecessary referral to a gynecological oncology, anxiety regarding ovarian cancer, expensive MRI examinations, incorrect surgical planning, oophorectomy instead of myomectomy. So you see now how a misdiagnosis can cause mismanagement of the patient or the extra expenses which are not necessary for the patient. So let me briefly take you again down the lane of our pelvic anatomy. So this is just a brief overview. So here with the urinary bladder there, then with the uterus there, the ovaries there on either side, the right and the left side ovary there. So that's the same anatomical diagram there. This is a transmural fibroid. You can find it there. Then you can have the subserosal fibroids there. Then you can have an intramural fibroid there. Then you've got the submucosal fibroid which are here. Then you've got the intramural fibroid. Then you see now what we have is a pedunculated fibroid. So this is a pedunculated subserosal. We can also have a pedunculated submucosal fibroid, which is inside the endometrial cavity. but this one is a pedunculated subserosa, it's outside. So now, you must understand where the structures originate. That's the very basic and very fundamental attribute that you must have. You must understand where anatomy or structures are originating from. If it is a pathology, where is it coming from or originating from? So the uterus, the central pelvic organ, continuous with the cervix, is surrounded by the myometrium and the ovary. They are mobile, connected by ovarian ligament, and they contain the follicles. They contain the follicles. So now, the pedunculated fibroid originates from outer myometrium. So it originates from outer of the myometrium. So here, like that. So remains attached to the uterus by a stalk. It simply extends towards the adnexia. So it's extending outside the uterus toward the adnexia. So the problem, it has got a stalk, so it can twist and cause a lot of pain, a pedunculated fibroid. So why fibroids mimic ovarian tumors? Why do you know why fibroids? Do you know why fibroids mimic ovarian tumors? So several reasons explain the confusion. So let me highlight the major ones. It's the larger size. So large fibroids distort the pelvic anatomy. They will distort the pelvic anatomy, then you can mislead them for ovarian tumors. Thin stalk, the uterine attachment may be invisible. You might not see the connection with the uterus. Degeneration also can be another causative factor. So fibroids become heterogeneous. Calcification so produces dense shadows and then cause the confusion. Ovary not visualized. So the normal ovary may hide behind the lesion. So you can have a superimposition where the ovary itself is hiding from is being masked by the pedunculated fibroid. Then you can miss it easily. So the common solid ovarian masses. These are the common solid ovarian masses. So there's a ovary there. Then you can see there's an ovarian mass there, which is a fibroma. Then we've got a fibroma there. There's another mass there, another mass there. So major differential diagnoses include, these are the differentials for a pedunculated fibroid. The ones which are benign, we with a fibroma, we with a fibrothecoma, we with a Brenner's tumor, we also with the mature cystic teratomas. So these are differentials to a pedunculated fibroid. So at times it becomes very difficult for you to say, is it a pedunculated fibroid or is it the differentials? So malignant, so epithelial ovarian carcinoma, dysgeminomas, the metastasis. So these are the malignant lesions of the ovary that can also masquerade as pedunculated fibroids. So the grayscale features of a pedunculated fibroid. These are the features that you must master back to back. So you see here, you have with the uterus there, with the stalk, and then you've got a pedunculated fibroid there, and you can see here, there's a calcification that we have in this fibroid, and then you can see here, this is the degeneration, so there's a central cystic degeneration of the fibroid there. So the typical appearance of a pedunculated fibroid, the shape is round, or it can be oval, it can be well defined. It's not sequential, so it has to be well defined. So the echogenicity of a pedunculated fibroid, it's usually hypoechoic and sometimes heterogeneous. So you can see here it's hypoechoic and it can be heterogeneous there with mixed components, mixed portions like that. So the margins, they are mostly very smooth and well circumscribed. So you can see the margins are well circumscribed and very smooth like that. Okay. Then the posterior shadowing. So very common, especially when fibrous and calcified. So you can also have like this. You can see there is posterior acoustic shadows because of the calcifications in the fibrous tissue of the fibroid itself. So those things can now also mislead you to think of a malignant transformation, because malignant tumors also, they tend to have posterior acoustic shadows. So you can see here, that's degeneration now. So produces cystic spaces, mixed echogenicity, and irregular appearance. So those are the other features or other attributes of a penangular fibroid. So they are variable depending on the maturity, the stage, the feeding that is getting. Understand? If it's getting enough blood supply, if it's not getting enough blood supply, start to degenerate, then you can have central cystic space like that. So grayscale features of solid ovarian tumors. So now I was talking about the grayscale sonographic sign of a penangular fibroid. Now let's talk about the grayscale for the ovarian tumors. Typical findings include ovarian origin, irregular margin sometimes, then it can have internal vascular tissue and papillary projections, ascites, malignant. So if it's a malignant or a cancerous ovarian mass, is mostly associated with ascites or fluid in the peritoneal space. That's the malignant ascites. So virality, so it can affect both sides. Complex cystic solid pattern, unlike fibroids, ovarian tumors usually replace the ovarian tissue. So they normally replace the ovarian tissue because they are originating from the ovaries. So step one, what you're supposed to do when you're doing an ultrasound scan to identify these subtle or these confusing lesions, you must find both ovaries. One of the biggest mistakes is stopping after finding the mass. So if you see a mass, don't stop there. You must identify the fibroid. Otherwise, you're going to mistake the origin. Is it originating from the uterus? Is it originating from the ovary itself? So that can be a bit confusing. Always ask, can I identify both ovaries separately? That's a question that you are asking yourself as you are doing the sonar. So certain questions you have to ask yourself, not necessarily the patient, but the patient doesn't see the internal structures. You understand? You are the one asking yourself. If the ipsilateral ovary is seen separately, so the word ipsilateral means is in the same side. So you can have a mass, then check on that side if there is an independent or separate ovary. So the lesion is unlikely to originate from the ovary. This single observation often solves the case. So if you know if the lesion is originating from the ovary or is not, that can solve the puzzle. So the bridging vessel sign. So guys, ladies and gentlemen, you must write this down. Write this down. The bridging vessel sign. The bridging vessel sign. So most important Doppler sign. Color Doppler demonstrate vessels running from the uterine myometrium directly into the mass. These vessels form the bridging vessel sign. So you can see if you have got a vessel that is coming from the myometrium, then going to the to feed the mass. That is what we call the bridging vessel sign. So you can see the vessel there. That's the bridge there. That's the bridging vessel. Why it matters? Why it matters? It confirms uterine origin, not ovarian origin. So if you see a bridging vessel that is coming from the myometrium and feeding the lesion, then you must be convinced that this lesion is originating from the uterus, not the ovary cell. So the bridging vessel sign is very critical for us to identify and differentiate the origin of a lesion, ovarian or uterine. So the Doppler characteristics. So the penangular fibroid, it has got peripheral vessels, low vascularity, bridging vessels, peripheral circumferential flow, and minimum internal flow. Whereas an ovarian tumor, it has got random internal vascularity, the central flow, chaotic branching, multiple penetrating vessels, not a bridging vessel, hypervascular malignant tissue. So it is got hypervascular if the lesion is malignant, is cancerous. So you can see the differentiation, the Doppler characteristics. So peripheral vessels, low vascularity, the bridging vessels, peripheral circumferential flow, minimum internal flow. So the ovarian tumor, random internal vascularity, central flow, chaotic branching, multiple penetrating vessels, and hypervascular malignant tissue. So, ladies and gentlemen, you must appreciate this. The value or the role of Doppler imaging to differentiate the origin of the masses. So this is very, very critical. So that those shadows cannot confuse you. You cannot be confused by the shadows, which is which. So the power Doppler is more sensitive than color Doppler, useful when blood flow is slow, fibroid stalk vessels are tiny, conventional Doppler appears negative. Power Doppler frequently reveals the vascular pedicel. You can imagine how powerful the power Doppler can be and how useful it can be in order to localize the origin of an ovarian or a uterine lesion. So it can differentiate, it can localize. Power Doppler is very magical when it comes to these masses. So you must have an interplay of all the types of Dopplers for you to get the answer. The spectral Doppler pediculated fibers usually demonstrate higher resistant flow, moderate vascularity. Ovarian malignans often show lower resistant flow, greater neovascularity. Spectral Doppler supports the diagnosis but should not be used in isolation. So we are saying that in as much as we are saying that pedunculated fibroids usually have got a high resistant flow and a moderate vascularity, and the ovarian malignancy have got a lower resistance and greater neovascularity, we must not just use spectral Doppler in isolation. So it must combine with the other features, the B mode findings and the power Doppler findings. You must correlate all those things to come up with a comprehensive and very correct diagnosis. So the comparison table, the feature pedunculated fibroid ovarian mass. So the origin, uterus or ovary. The bridging vessels, they are present or absent. The separate ovary, usually visible, not separate. So posterior shadow for pedunculated side is common, whereas in solid ovarian mass is less common. Peripheral flow is common in a pedunculated fibroid, whereas solid masses is variable. Central vascularity minimum, often marked. Calcification frequent, less common. Mobility moves the uterus, it's independent. So you can see now how you can differentiate a pedunculated fibroid from a solid ovarian mass. Let me repeat again the origin. This one from the uterus, this one is from the ovary. Bridging vessels, they are present in a pedunculated fibroid, they are absent in ovarian mass. Separate ovary, usually visible, not visible, because this is when it's originated from the ovary cell. Posterior shadow is common in pedunculated fibroid, where it's less common in ovarian mass. Peripheral flow is common in pedunculated fibroid, yet is variable in a solid mass. Central vascularity is minimum in a pedunculated fibroid, whereas often marked in an ovarian mass. Calcification, they are often frequent in a pedunculated fibroid, whereas less common in ovarian mass. Mobility moves the uterus, the pedunculated fibroid, whereas the solid ovarian mass is independent of the motion of the uterus. So what are the common pitfalls, ladies and gentlemen? What are the common pitfalls? What are the common pitfalls? Do not rely on the size, the echogenicity, the location. Do not rely on size, echogenicity, and the location. So the pitfalls include degenerating fibroid, broader ligament fibroid, large ovarian fibroma, pregnancy, obesity, poor bladder filling. These are the common pitfalls. So we are saying the location on its own is not enough to say that this is coming from the ovary or uterus. The echogenicity on its own cannot be used to differentiate or to localize the origin of a mass. The location itself, it can go anywhere, but with where it is attached to the uterus, for instance. So the pitfalls include degenerative fibroid, broader ligament fibroid, large ovarian fibroma, a pregnancy, obesity, poor bladder filling. So examination technique now, use trans-abdominal scan, then transvaginal. So you have to start from the trans-abdominal, then you do the transvaginal scan. Evaluate both ovaries, uterine contour, the cervix, the cul-de-sac, color Doppler, power Doppler. Sweep through the entire pelvis. Never evaluate one image. Never evaluate on one image. This is your Bible. Take note of that and write it down. Never evaluate one image. Evaluate multiple images in different planes, in dynamic and static views. So when now does MRI help? When now does MRI help to differentiate these pedunculated fibroids from ovarian mass origins? So MRI is recommended when ovaries cannot be identified, Doppler findings are inconclusive, massive degeneration obscures the morphology, and then surgical planning is required. So those people now that when we need to plan for the surgical management, then they have to use MRI or when you want to embolize, embolization, you also have to consider using MRI instead of X-ray. So you can see the peduncular fibroid on MRI there. So you can see the peduncular fibroid on MRI there. So MRI clearly demonstrates the uterine attachment, the stalk tissue composition in ovarian anatomy. So those are the major advantages, the merits of using MRI over ultrasound. So you must write this down and understand everything for you to master differentiating the origin of pelvic lesions or masses. So now, here I have given you a symbol suggested report. How do you write the report? So this is a simple report that you can use, a template that you can use. So finding solid hypoechoic adnexal mass measuring that much centimeters. So the bridging vessels are demonstrated extending from the uterine myometrium into the lesion. Both ovaries are identified separately and appear normal. No papillary projections or ascites noted. The impression findings are most consistent with the pedunculated subserosal uterine leiomyoma rather than an ovarian neoplasm. Ladies and gentlemen, this is a report that looks like any other, but it's not a typical report that you know of, because this is a detailed report that is capturing the differences between a mass of ovarian origin and a mass originating from the uterus. Let me read the template for you again. Before you take these notes, please write your own template or save this template, please. You can simply screenshot it from your screen like that. Stop the video, screenshot it, the template, then you can edit it, or you can just write it down and then have it as part of your armamentary of ultrasound. So, solid hypoechoic adnexal mass measuring that much centimeters. Bridging vessels are demonstrated extending from the uterine myometrium into the lesion. Both ovaries are identified separately and appear normal. No papillary projections or ascites. Bridging vessels are demonstrated extending from the uterine myometrium into the lesion. These are the key words, guys. These are the key words. Please, 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 please understand this. The bridging vessels, they show that it's a peduncular fibroid. So the impression findings are most consistent with a pedunculated subserosal uterine leiomyoma rather than in ovarian neoplasm. So now, what are the key take-home messages? Always identify both ovaries. Look carefully for the uterine stalk. Search specifically for the bridging vessel sign. Use both color and power Doppler. Correlate grayscale findings with vascular patterns. MRI is valuable when ultrasound remains indeterminate. So these are your take-home messages. Please, these are for you. Always identify both ovaries. Look carefully for the uterine stalk. Search specifically for the bridging vessel sign. Use both color and power Doppler. Correlate grayscale findings with vascular patterns. MRI is valuable when ultrasound remains indeterminate. So now, let's have an algorithm. This is an algorithm. This is a chart. You must have this also in your room, guys. This chart helps you to make the workflow of assessing these pelvic masses or lesions very easy. So, solid adnexal mass. Can both ovaries be identified? Yes. If no, consider a peduncular fibroid. Use color Doppler. Bridging vessels present? Yes. Peduncular fibroid. No. Assess ovarian vascularity and morphology. Subspecies features? Yes or no? If yes, ovarian neoplasm, MRI or gynecology referral. If no, indeterminate, then use MRI. This algorithm is very, very critical. Solid adnexal mass, can both ovaries be identified? So you're asking yourself the questions and answering them. Yes or no, yes or no. If the both ovaries can be identified, then consider it a pendular fibroid. If not, use color Doppler. Bridging vessels present, is no. If yes, it's a pendular fibroid. If no, assess ovarian vascularity and morphology. Assess ovarian vascularity and morphology. Are there any suspicious features? Yes, then ovarian neoplasm, MRI or gynecologic referral. If no, then indeterminate, then go for an MRI. Ladies and gentlemen, these are the practical cues. These are the final practical cues for this presentation. The bridging vessel sign is the simple, single, most helpful Doppler feature for establishing a uterine origin. The bridging vessel sign is the single most helpful Doppler feature for establishing uterine origin. Seeing a normal ovary separated from the mass strongly favors a pendular fibroid. Central chaotic vascularity, papillary projections, ascites, and inability to identify normal ovarian tissue increase concern for an ovarian neoplasm. Always combine grayscale morphology, Doppler assessment, and systematic pelvic survey rather than rely on imaging feature alone. Ladies and gentlemen, this brings us to the end of this presentation. This is advanced ultrasound. It's no longer the ultrasound where you just say, rush, say it's a mass, write the report, send the patient away. This is a characteristic masterclass ultrasound piece of a lecture where we are going into the depth of ovarian masses, how to differentiate them, so that we don't cause unnecessary panic, we don't cause unnecessary expenses, we also don't have to cause unnecessary complications to the patients. Ladies and gentlemen, I thank you so much. Don't forget to comment, like, and share our educational content. Let's meet again in the next episode. Thank you.
Hello, good people. How are you doing? So the case that I have today will shock you. It's one of those things that are very rare. So I need you to watch until the end of this video and you can see the shocking findings. I hope and I wish that this will shock you as I was shocked also because it's my first time, and I hope most of you it's also will be your first time to see this type of a pathology. So the first that is a transvaginal ultrasound. So you can see here there's a fibroid. This is not the shocking thing. So this is a nice subserosal fibroid there. This is the subserosal fibroid there. You can see this peripheral vascularity. That's our uterus there. You can see the blood vessels there. That's the bladder there is fine. So the fibroid is here. That's a well outlined fibroid there. Well outlined fibroid there. Well outlined fibroid there. So you can see this one microvascular flow. There you can see so there's no color flow inside. You can see the cervix here nicely. The cervix here nicely. There is the thing that I'm talking about. You can see this is a vaginal wall mass. So there's got the honeycomb structure. You can see this. So what do you think this is, guys? This one, this lesion there. What is this? That's just adjacent to the vagina there, on the vaginal wall. There we have it. You can see it has got cystic components. It has got cystic areas like that. What do you think this thing is? What is this? So let's do it together. This mass with the honeycomb structure, mixed solid, and cystic portions like that. What is that? What is that? What do you think that thing is? What is that? So I need you to brainstorm on it. Me, I'm still shocked. I am very much shocked what that thing is. But let me say my thinking in this case. I am thinking of a high density cyst. So a vaginal high density is very rare, but the morphology of that mass now, it is called the morphology of an echinococcus cyst, high density cyst, the side structure that you've seen there. So you can see here, that's my thinking, my line of thinking, that this is a vaginal echinococcus cyst, but it's a very rare finding, if not one of its own, if not one of its own. So I hope you are also giving you differentials. If you think otherwise, I need you please to send your results on the comment section to say that I think this is what this thing could be. What do you think that is? What do you think that is? Mostly these identity cysts, they do happen inside the liver. That's the most common site for echinococcosis or echinococcal cyst. But in this case now, it's my first time to see a high density cyst that is manifesting itself in the vagina. So the referring clinician was saying that there is a mass in the urethral mass, but it is not in the urethra on ultrasound, as you have seen. So give me your suggestions. I also need a pool of differentials. What can this be? What can that be? What can that be? What can that be? Initially, I thought it is bowel, but there's no bowel motion, as you can see. The fluid is the only one that is moving a bit. So, what's your take on this, mass? What's your take? What's your take? So, let's talk, guys. Let's discuss. I need also your assistance. I might be wrong, but my thinking is that this is an echinococcal cyst, a vaginal high density cyst. So, it's a very rare manifestation. So, I think I'm one of those blessed to have witnessed it during my time of practice. So I just saw it today, just now. So I decided to upload this video because it's one of those most interesting cases. So, but I need your take. I can't be alone in this race, guys. Don't leave me alone. Let's go together. Let's fail together. Let's fail together. Yeah, this was a straightforward diagnosis. Yeah, this was a straightforward diagnosis. Do you know what? Yesterday I did the same patient, a transabdominal sonar. I just reported on the serosal fibroid, but I couldn't pick this one from a trans. So now the mass is presenting low. The doctor sent the patient back. So now we are seeing this one. You see, it's more here, it's more here. So what's your take? What's your take? What's your take? What's your take? Help me, guys. I am also stuck. I am also stuck. But there's no flow, there's some internal or Rolex formation, there's some movement there. And this is the kinetic energy from the probes, that these particles are now moving inside this, but they are not blood vessels. So let's do it together under the comment section. Give me your thoughts. Thank you so much. Don't forget to subscribe and share. Also give your comments and let's talk.
Hello everyone, and how are you? How are you doing? I hope you're doing very well. So we are going to start on our American Registry for Diagnostic Medical Sonography examination preparation questions. So in this session, we do have got 20 typical questions, explanations, answers. So if you want to enhance your practice as well, even if you are not writing for the American Registry exams, this is ideal for you to have an in-depth understanding of the medical ultrasound. So the American Registry for Diagnostic Medical Sonography, a RMDMS examination system, is the gold standard for certifying medical sonographers globally. So to earn an RDMS credential, a candidate must successfully pass two separate computer-based exams within a 5-year period: the foundational physics and at least one clinical special exam. So this physics exam is compulsory. So ARDMS examination tips. So this one is the obstetric part that I am going to discuss with you in this session. So these are the tips for a typical obstetrics examination session. So the American Registry questions, they are multiple choice questions, and then you have to make a choice from there. So these questions reflect the clinical reasoning and image interpretation style commonly encountered on the ARDMS obstetric and gynecology examination. So the tips: you must know fetal anatomy in all standard planes. You must memorize first trimester pregnancy failure criteria, crown rump length and mean sac diameter thresholds. You must understand the umbilical artery, middle cerebral artery, uterine artery, and the ductus venosus Doppler patterns. You must be able to differentiate common fetal anomalies such as anencephaly, spina bifida, omphalocele, gastroschisis, duodenal congenital diaphragmatic hernia. So you must master fetal biometry, estimated fetal weight calculations, amniotic fluid assessment, placenta abnormalities, and multiple gestational evaluation. So you must master those ones if you want to pass these American Registry examinations. So let's go into the questions, and then I need you to attempt the question self-assessment. So the next page I will be giving the answers. The first page I give you the question. So attempt on your own to attempt, then self-evaluate yourself to see how far you can go. So question number 1: during a routine first trimester scan at 8 weeks, a fetal pole measures 16 millimeters, crown rump length, but no cardiac activity is demonstrated. So this is what we have here. That's the images. So what is the most likely diagnosis? A, pregnancy of unknown location. B, missed miscarriage. C, viable pregnancy. D, ectopic pregnancy. So the question again: during a routine first trimester scan at 8 weeks, a fetal pole measures 16 millimeters crown rump length, but no cardiac activity is demonstrated. So what is the best diagnosis for that? A, pregnancy of unknown location. B, missed miscarriage. C, early viable pregnancy. D, ectopic pregnancy. So now let's move on to the answer. So the correct answer for this question is a missed miscarriage. Explanation: according to accepted first trimester ultrasound criteria, a crown rump length which is above or equal to 7 millimeters with absent heartbeat is diagnostic of pregnancy failure. Repeat scanning is unnecessary if image quality is adequate. So you must make sure that the image quality is adequate. Otherwise, you can also make a misdiagnosis because the quality of your images are quite poor. So that is the correct answer for question number 1. So question number 2: a patient at 20 weeks undergoes fetal biometry. Which parameter is most accurate for pregnancy dating in the second trimester? A, the female length. B, the head circumference. C, biparietal diameter. D, abdominal circumference. A patient at 10 weeks undergoes fetal biometry. Which parameter is most accurate for pregnancy dating in the second trimester? A. Female length. B. Head circumference. C. Biparietal diameter. D. Abdominal circumference. Okay, so let's go to the answer. So the uh, correct answer now is B, which is the head circumference. So explanation: head circumference is less affected by fetal head shape than BPD and is therefore preferred for dating. So the correct answer for dating in the second trimester, the most accurate, is the head circumference, which is less affected by fetal head shape than the BPD and is therefore the preferred choice. So let's go to the next question. Question number 3. A sonographer observes the fetal stomach positioned on the right side of the abdomen. So what should be suspected? A sonographer observes a fetal stomach positioned on the right side of the abdomen. So what should be suspected? A. An omphalocele. B. Situs inversus. C. Duodenum atresia. Then D. gastroschisis. A sonographer observes the fetal stomach position on the right side of the abdomen. What should be suspected? A. Omphalocele. B. Situs inversus. D. Duodenal atresia. Then D. gastroschisis. So our correct answer is B. That's situs inversus. The fetal stomach is supposed to be positioned in the left side. That's the normal position. So question number 4. During Doppler assessment of the umbilical artery at 32 weeks, absent any diastolic flow is demonstrated. What does this indicate? During Doppler assessment of the umbilical artery at 32 weeks, absent any diastolic flow is demonstrated. What does this indicate? A. Normal placental function. B. Placental insufficiency. C. Polyhydramnios. D. Maternal diabetes. During Doppler assessment of the umbilical artery at 32 weeks, absent any diastolic flow is demonstrated. What does this indicate? A. Normal placental function. B. Placental insufficiency. C. Polyhydramnios. D. Maternal diabetes. So the correct answer is B, which is the placental insufficiency. The explanation: absent reversed end diastolic flow indicates severe placental resistance and fetal compromise. So that's placental insufficiency. Our answer is B. Now, question number 5. Which fetal structure should always be seen in the standard 4-chamber view? Which fetal structure should always be seen in the standard 4-chamber view? A. Pulmonary veins. B. Left ventricular outlet tract. C. Both atria and the ventricles. D. The aortic arc. Which fetal structure should always be seen in the standard 4-chamber view? That's the standard 4-chamber view. The standard 4-chamber view. A. Pulmonary veins. B. Left ventricular outlet tract. C. Both atria and ventricles. D. The aortic arc. So our answer is C. Both atria and the ventricles are supposed to be seen in the 4-chamber view. Question number 7. Which biometric measurement is most affected by fetal growth restriction? Which biometric measurement is most affected by fetal growth restriction, IUGR? A. Biparietal diameter. B. The female length. C. Abdominal circumference. D. The head circumference. Which biometric measurement is most affected by fetal growth restriction? A. Biparietal diameter. B. Female length. C. Abdominal circumference. D. The head circumference. So our correct answer is C, which is the abdominal circumference, the one that is mostly affected by fetal growth restriction. Question number 8. Which vessel normally carries oxygenated blood from the placenta? Which vessel normally carries oxygenated blood from the placenta? A. umbilical artery, B, umbilical vein, C, ductus arteriosus, D, the aorta. Which vessel normally carries oxygenated blood from the placenta? A, umbilical artery, B, umbilical vein, C, ductus arteriosus, D, the aorta. So the correct answer is the umbilical vein, which is B, the umbilical vein. That's B. Question number 9. Which abnormality is most associated with increased knockout translucency? Which abnormality is most associated with increased knockout translucency? A, Down syndrome, B, clubfoot, C, renal agenesis, D, hydrocephalus. Which abnormality is most associated with increased knockout translucency? A, Down syndrome, B, clubfoot, C, renal agenesis, D, hydrocephalus. So our correct answer is A, which is Down syndrome. Down syndrome is the correct answer. Question number 10. The lambda or twin peak sign indicates. So the lambda or the twin peak sign, what does it represent? A, monochorionic twins, B, dichorionic twins, C, twin to twin transfusion syndrome, D, conjoined twins. The lambda twin peak sign indicates A, monochorionic twins, B, dichorionic twins, C, twin to twin transfusion syndrome, D, conjoined twins. So the correct answer is B, which is dichorionic twins. Dichorionic twins. Question number 11. Which fetal presentation places the buttocks closer to the cervix? Which fetal presentation places the buttocks closer to the cervix? A, cephalic, B, bridge, C, shoulder, D, transverse. Which fetal presentation places the buttocks closest to the cervix? A, cephalic, B, bridge, C, shoulder, D, transverse. So the correct answer is that's a bridge presentation. That's a bridge presentation. Question number 12. Which fetal anomaly is classically associated with the double bubble sign? Which fetal anomaly is classically associated with the double bubble sign? A, jejunal atresia, B, duodenal atresia, C, esophageal atresia, D, imperforate anus. Which fetal anomaly is classically associated with the double bubble sign? A, jejunal atresia, B, duodenal atresia, C, esophageal atresia, D, imperforate anus. So the correct answer is B, which is duodenal atresia. Question number 13. Polyhydramnios is defined as A, AFI less than 5 centimeters, B, AFI above 24 centimeters, C, AFI 10 centimeters, D, MVP 2 centimeters. So polyhydramnios is defined as A, AFI less than 5 centimeters, B, AFI greater than 24 centimeters, C, AFI 10 centimeters, D, MVP 2 centimeters. So the correct answer is B, AFI above 24 centimeters. And AFI above 24 centimeters is classified as polyhydramnios. Question number 14. Which Doppler vessel is commonly used to assess for fetal anemia? Which Doppler vessel is commonly used to assess for fetal anemia? A, umbilical artery, B, uterine artery, C, the middle cerebral artery, D, ductus venosus. Which Doppler vessel is commonly used to assess fetal anemia? A, umbilical artery, B, uterine artery, C, middle cerebral artery, D, the ductus venosus. So our correct answer is C, which is the middle cerebral artery. The middle cerebral artery is the correct answer here. Question number 15. Which feature differentiates gastroschisis from omphalocele? Which feature differentiates a gastroschisis from an omphalocele? A. Liver outside the abdomen. B. Membrane covering the bowel. C. No covering membrane. D. Midline defect. Which feature differentiates a gastroschisis from an omphalocele? A. Liver outside the abdomen. B. Membrane covering the bowel. C. No covering membrane. D. Midline defect. So the correct answer is C. No covering membrane in a gastroschisis. So there's no covering membrane. But in the omphalocele, that's where we find a covering membrane. Question number 16. Which structure bypasses the fetal lungs? Which structure bypasses the fetal lungs? A. The ductus arteriosus. B. Portal vein. C. Umbilical artery. D. The pulmonary vein. Which structure bypasses the fetal lungs? A. Ductus arteriosus. B. Portal vein. C. Umbilical artery. D. The pulmonary vein. So the correct answer is ductus arteriosus. The ductus arteriosus. A. That's the correct answer. A. Ductus arteriosus. So now let's go to question number 17. Which biometric parameter is least useful for estimating the fetal weight? Which biometric parameter is least useful for estimating the fetal weight? A. HC, head circumference. B. Abdominal circumference. AC. C. FA with the femur length. D. The mean seg diameter. Which biometric parameter is least useful for estimating the fetal weight? A. HC. B. AC. C. FA with D. The seg diameter. So the correct answer is the mean seg diameter. The seg diameter. Question number 18 now. A fetus demonstrates absent calvarium with exposed brain tissue. What is the diagnosis? A fetus demonstrates absent calvarium with exposed brain tissue. What is the most likely diagnosis? A. Hydrocephalus. B. Holoprosencephaly. C. Anencephaly. D. Encephalocele. A fetus demonstrates absent calvarium with exposed brain tissue. What is the most likely diagnosis? A. Hydrocephalus. B. Holoprosencephaly. C. Anencephaly. D. Encephalocele. So our correct answer is C, which is in anencephaly. Anencephaly is the correct answer there. Anencephaly. Question number 19. The fetal bladder should normally fill and empty approximately every. The fetal bladder should normally fill and empty approximately every A. 5 minutes. B. 30 to 45 minutes. C. 2 hours. D. 4 hours. The fetal bladder should normally fill and empty approximately every A. 5 minutes. D. 30 to 45 minutes. C. 2 hours. Then D. 4 hours. So the correct answer is B, which is 30 to 45 minutes. The fetal bladder should empty every 30 to 45 minutes. So question number 20, which is the last question for this session. Which Doppler index increases with worsening placental resistance? Which Doppler index increases with worsening placental resistance? A. The pulsatility index PI. B. Peak systolic velocity only. C. Mean velocity. D. The acceleration time. The question again. Which Doppler index increases the worsening placental resistance? A. Pulsatility index PI. B. Peak systolic velocity only. C. Mean velocity. Then D. The acceleration time. So our correct answer is A, which is the pulsatility index PI. The explanation: as placental vascular resistance increases, the pulsatility index PI raises, resistance index RI rises. So any diastolic flow decreases and may become absent or reversed in severe placental insufficiency. So that's the correct explanation answer. So it is the pulsatility index PI that increases. So, ladies and gentlemen, this brings us to the end of this session. So, I want you to do a self-evaluation before you look at the answer. Try to write your answer down, then compare, assess yourself, then you evaluate yourself. I also need your self-evaluation certificates. Um, Give yourself your certificate. I'm not going to give you the certificate myself, but your certificate is your own self-evaluation. Certify yourself to say that I'm competent enough. I am ready for the exam. So I'm going to keep on giving you these American registry examination questions. Then you revise as much as you can. When you feel that you are ready, then you can attempt the examination. All the best are those who are writing the registry examination. All the best, all those who are also learning, acquiring knowledge. This is very useful for your practice. Do as many as you can and then learn as much as you can. Thank you so much. Don't forget to share this information, like our videos, and also comment. Thank you. Welcome, colleagues. How are you? So, what I am giving you now, this is the gold of first trimester ultrasound scan. I am giving you diamond fields of first trimester ultrasound scan for free. These are the diamonds, not emeralds. These are the diamonds. So this is the atlas of first trimester pregnancy failure. This is the atlas. So below are representative ultrasound appearance of the most common types of first trimester pregnancy failure. So number one, that's a normal pregnancy for comparison. So a normal pregnancy, you are supposed to see the decidual array sign, the double decidual sign, that ring that we have. And if you zoom it, you can see the yolk sac there, the yolk sac is present there. So the yolk sac is present there. So this is the standard normal ultrasound scan that you all know of. But that is so good when it is like that. But it doesn't always follow like that you're going to see the normal. It is the abnormal that is now a going concern. So let's talk about the abnormal one. So the unembryonic pregnancy, the blighted ovum. So here you can see there, we can't see the gestational sac, neither can we see the embryo. There is nothing there. So there's nothing there. So say the view of an empty gestational sac or blighted ovum. So you can see there's nothing there. But we said you don't just jump and say this is a blighted ovum without measuring the mean gestational sac to be equivalent to or above 25 millimeters. As long as it is below 25 millimeters, you give it the benefit of the doubt. You can rescan it after a week or 2 weeks to see if the embryo start to develop. So this is the hallmark of a blighted ovum, an embryonic pregnancy. There is nothing. Yet the mean sac diameter is above 25 millimeters. So the embryonic demise, which is the so-called the missed abortion, the embryonic demise. So you can see here there is an elongated echogenic something that is here, that is echogenic and elongated there. It's shrunken. So that is the dead embryo. So the embryos died there, the embryos died. You can see there, you can see the dead embryo there, the dead embryo. If as long as it is above 7 centimeters and there is no cardiac activity, then you are confident that you're dealing with a case of what? Of a missed miscarriage or a dead embryo. So you must see an embryo inside with no cardiac activity on condition that that same embryo is got a diameter that is above 7 millimeters. I hope this is percolating well and you are getting it nicely. Okay. Inevitable miscarriage. Inevitable. inevitable. It means that it can't be stopped. It can't be stopped. So when you see that the pregnancy is now inside the cervix, is on its way out, that is an inevitable miscarriage. You cannot save that. So when the os is closed, is open, and the vaginal canal is now the cervical canal is now open, you are supposed to know that we are in the highway out. So that's an inevitable uh, miscarriage. So now, incomplete miscarriage. So when there is an incomplete miscarriage, there are episodes, there are periods in the first trimester that someone comes, they were pregnant, they started bleeding, then they come for the sonar. You can see retained products. So returned products, they appear like that. You see that there's an echogenic endometrium thickened like that, and then you can see there is hyperemia or hyperperfusion or enhanced myometrial perfusion due to the retained products of what? Of conception. So you must not just rush to say everything that you see is a RPOs or is an incomplete miscarriage. It might be endometrial hyperplasia, it might be endometrial cancer. So the history is very critical. Was someone pregnant? Were they bleeding? Then you can talk of an incomplete miscarriage. A complete miscarriage. So complete spontaneous abortion. So you can see there that the endometrial is there and it's thin. There are no retained products inside. So this is a complete miscarriage. So do not confuse a complete miscarriage with a normal period, because with a miscarriage we must have a history of pregnancy first before someone can miscarry. Otherwise it's a period or it's another type of bleeding, abnormal PV bleeding. So now we also have got what is called the subchorionic hemorrhage. So the hemorrhage on this on the other side of the chorion, there on the other side of the chorion there is what is called the subchorionic hemorrhage. So you can see here the gestational sac there, but you can see that there's another anechoic space there, that ring that you are seeing there. So this is a hemorrhage. That's the bleeding in the subchorionic space. So the hemorrhage in the subchorionic space there, there's hemorrhage in the subchorionic space. You can see uh, in here it seems as if the gestational sac is detached, and then there's a hemorrhage all over here. So you must take note of a subchorionic hemorrhage and the threats that it can pose to the existing pregnancy. So please, this atlas will help you. It will help you to identify those soft markers of pregnancy failure. So the irregular gestational sac. So an irregular gestational sac that is not circular in all that is another sign of a pregnancy failure. You can see this is an elongated gestational sac. Don't see this and see that it is normal, and then you record that is normal, and then you try to measure the mean sac diameter like that. No, you see how it is like. Look, this is an irregular sac. Look how it is like that. Look how it is enlarged gestational sac like that. You see this one. So what we have here, guys, now is another sign of pregnancy that is failing. So it's an irregular gestational sac like that. So also an abnormal yolk sac. You see, look at this calcified yolk sac that we have there, a calcified yolk sac there, and then you can see this calcified rim of the yolk sac there, and which is also irregular. This is also another sonographic feature of a failing pregnancy. The yolk sac is also an indicator of a pregnancy that is likely to fail or that is going to fail. So you must look at the anatomy, the architecture of the yolk sac itself, if it is regular or well outlined at the same time without calcifications. So do you guys do that? Do you really check the yolk sac and analyze it for any sign of pregnancy failure? Yes, probably 19% do, probably 15% do, probably 10% do, probably 5, probably even 1% do. Do not leave this these markers. These are the silent markers. That's why you say that I did a sauna today. Then someone comes after a week, they're bleeding, they're already miscarrying. Say, what happened? The pregnancy was very normal, because you overlooked these soft markers. You did not check them nicely. So when the patient comes, then they are now bleeding and all that. Then you say, I did my job, everything was fine. You understand? That kind of stuff. You understand? It is because of that. It is because of this. So the foundation is always very critical. Without the foundation, we cannot have structures. So pregnancy of unknown location. I have discussed about this. A pregnancy of unknown location is not a pathology. It is not a diagnosis. It is a condition, a transitional condition. It's a condition that is happening, but it's just like when you wash your clothes, they are still wet. It's a transition. When they dry up, they will not be wet anymore. Or if you keep soaking them in water, they will keep on being wet like that. You understand? So the condition, we don't know where the pregnancy is. You understand? That's a condition. But after some time, you will know. It was an ectopic. Oh, it was just there in the endometrial cavity. I did not see it nicely. I did not use the TVs. I just used the transabdominal. You understand? Negligence, incompetence, use of outdated equipment, lack of experience are all confoundings when it comes to the diagnosis of some of these pregnancies of unknown origin. So the due diligence is to repeat. There's power in repetition. So the patient comes again, you check again, the pregnancy test is done again, they confirm the beta ECG if there are changes, you understand, to make sure that it was indeed not a pregnancy, it was a false positive pregnancy in the first place. You understand? So that's how we will get a definitive. When we get the definitive answer, now we are out of the phase where we say that this was a pregnancy of unknown. Now we know it was never there, or it was an ectopic pregnancy, or it was just an early pregnancy that was here to develop. Now it's there. I hope I'm making sense. So ectopic pregnancy mimicking pregnancy failure. So we can have an ectopic pregnancy that can also mimic pregnancy failure. There you can see there it will mimic. An ectopic pregnancy is not always a pregnancy failure because it can be a viable pregnancy, but it can pose risks. You understand? An ectopic pregnancy is not a pregnancy failure. It is a pregnancy outside the uterus. So it can, in the abdomen, if there's enough space and the attachments are fine, it can just reach term. I've seen one case where we monitored an abdominal ectopic pregnancy until the baby delivered a healthy baby in the abdomen outside the uterus. It's very possible. So do not confuse an ectopic pregnancy for a failed pregnancy. But though it poses far-reaching consequences when it's not diagnosed as well, it's life-threatening. I hope I am making sense. So now, early twin pregnancy with a single fetal demise, vanishing twin. So this is another manifestation of pregnancy failure. You can have one fetus normal in a twin pregnancy, then the other one is vanishing or is dying. So this is another case of a failed pregnancy. We are not saying both failed, one failed. You understand? Then the other can make it. So in vanishing twin, the remaining or the residual twin just can make it nicely. You understand? So it's a partial pregnancy failure where one fails and the rest continues. So if you are not careful, you do a sonar, you see the twins, you tell your patient that these are twins, but later on when they come, you see that's one. So you are going to be seen like someone who's incompetent. You must know that there is what is called the vanishing twin syndrome, a sign of pregnant failure. Then the other one may be probably vanished. That's what a professional does. So now, this collection covers the major ultrasound appearance encountered in first trimester pregnancy failure and is well suited for teaching case discussions or ultrasound training. So this is fundamental. It is very key. Those who are teaching, those who are doing case discussions, those are training. Please, this it is looks like not big like the Romag box, but this is the summary of the epitome of first trimester ultrasound scan. I don't know how to express it better than that. So the key diagnostic ultrasound criteria, the finding a crown rump length above or equal to 7 millimeters with no cardiac activity is a definitive pregnancy failure diagnosis. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. Thus an unembryonic pregnancy. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. So the empty uterus after previous confirmed pregnancy. So that's a complete miscarriage. Empty uterus after previous confirmed pregnancy. That's a complete miscarriage. Then the heterogeneous vascular tissue in uterus. So that is a retained product of conception. Heterogeneous vascular tissue in the uterus, that's a sign of retained product of conception, RPOCs. So gestational sac in the cervix, so inevitable miscarriage or abortion in progress. So that's an abortion in progress. Gestational sac in the cervix, so inevitable miscarriage and abortion in progress, or alternatively a cervical ectopic pregnancy. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. So it's a marker that the pregnancy might fail. So you must document like that. Irregular or collapsed gestational sac. So this is a poor prognostic sign when the gestational sac is irregular or collapsed. You must take note of that, guys. It's a poor prognostic sign. So the empty uterus with the positive beta HCG, empty uterus with a positive beta HCG. So that's a pregnancy or unknown location until proven otherwise. So if you have an empty uterus and the pregnancy test is positive, this is a pregnancy of unknown origin until proven otherwise. Ladies and gentlemen, besides your images or your pictures on your walls, your grandfather's pictures on your walls, I urge you to add the images of this atlas in the walls of your bedroom, so that each time you sleep, you are going to see these things over and over and over and over again, so that you don't miss anything. Someone who trained ultrasound in 1983 might have forgotten now that the abnormal yolk sac or a calcified yolk sac might be an indicator of pregnancy failure, and they've done several thousands of first trimester sonars, and most or some of the patients, they came back after a week or 2 weeks after having miscarried, and then you said everything was normal. You understand? Learning is on a continuum. Learning has to take place every time and every day. I thank you so much for your time. Please share this educational content with your colleagues and your friends. I urge you to do that for the sake of the patient. Thank you so much. Hello, colleagues. How are you? So, in this presentation, I am going to talk about early pregnancy failure. So, it doesn't automatically mean that when someone gets pregnant, that pregnancy is going to make it. It's either it's going to make it or it's going to fail, or there are going to be complications. So, here is a simplified approach to identifying pregnancy failure in the early stages. So, early stage pregnancy failure refers to a non-viable pregnancy during the first trimester. It is usually occurs before the 13th week of gestation. Ultrasound is the most reliable imaging tool for confirming viability and guiding patient management. So, ultrasound has got a very huge role in determining pregnancy failure and also identifying some of the early risks of pregnancy failure that you can identify. So, step one, when you're doing an early ultrasound scan, is confirm the location of the pregnancy. So you should ask, is the pregnancy inside the uterus? That's very fundamental. Is there more than one gestational sac? So you are now working as a professional. You are having questions that you need to answer. You don't just hold a probe without having questions that you ought to answer. So, could this be an ectopic pregnancy? So this is fundamental. This is very key. Is it intrauterine or is extrauterine? That's very pertinent. So look for the gestational sac itself. You must look at the double residual sign. Is it there or is it absent? Where is it? You should look for the yolk sac. You should look for the embryo or the fetal pore itself. Is it there? At what stage are we? Is it visible or not? So if you know intrauterine pregnancy is seen, then consider a pregnancy of unknown location, PUL. So I've discussed about that previously. You can check in my previous presentations, then you can see where I was presenting about the pregnancy of unknown origin or location. So you must exclude an ectopic pregnancy, correlate with the serial beta SG measurements, and repeat ultrasound scan if there is no pregnancy that is seen. So those are the other things that can be happening. It could be a pregnancy of an unknown location origin, then it could be an ectopic pregnancy, or you should consider beta ACG measurements and repeat the scan to make sure that the pregnancy was there in the first place. So step number 2 is assessing the viability. A viable pregnancy should demonstrate a gestational sac, a yolk sac, the embryo itself, and the cardiac activity. So you have to look at those things. So diagnostic criteria for pregnancy failure. Pregnancy failure is diagnosed when either of the following is seen: crown rump length equal to or above 7 mm with no heartbeat. So if you see that the crown rump length is equal to above 7 mm and you can't see a heartbeat, you must now think of a pregnancy failure. Or the mean sac diameter is above or equivalent to 25 millimeters with no embryo inside. These findings are considered definitive for a failed what? Pregnancy. Guys, ladies and gentlemen, write this down. This is your Bible. A crown rump length above or equal to 7 with no heartbeat. That is a sign of pregnancy. Definitive. If you measure this mean sac diameter is above or equivalent to 25 millimeters with no embryo, these are called a definite diagnosis for a failed pregnancy. I hope I am making sense there. I hope I'm making sense, okay? So step number 3, you must identify the type of early pregnancy failure. 1, an embryonic pregnancy or a blighted ovum. Ultrasound findings include a large gestational sac with no embryo, may or may not contain a yolk sac. So there might be or there might not be a yolk sac. So it doesn't mean that if there is a yolk sac, the pregnancy it's viable. Okay? So the diagnosis: mean sac diameter above or equivalent to 2 millimeters without an embryo is a sonographic sign, a definitive diagnosis of a failed pregnancy. So embryonic demise or miscarriage. Ultrasound findings: you see an embryo is present, but there's no cardiac activity, and the crown rump length is above or equivalent to 7 millimeters. So don't just rush to say that you are seeing a case of a missed abortion when it's not measuring less than or equal to 7 millimeters. So you must make it a point that when you're talking about an embryonic demise or a missed miscarriage, it has to conform to those. The embryo should be present. There should be no cardiac activity, and the crown rump length should be above or equal to 7 millimeters. So now, incomplete miscarriage. Ultrasound findings: thickened heterogeneous endometrium, retained products of conception, then increased vascularity on Doppler, which may be present or it might not be present. So those are the things that you have to look into when you're considering that a miscarriage has happened. So what are the ultrasound findings? What is it they're looking at? You don't just do a sonar nicodemously without understanding exactly. You must have a map. It's just like a builder who's building a house. They have what the design. You understand? They have the plan for the house. They know exactly what to do next. You understand? It's methodical. It's procedural. So when you're doing an ultrasound scan, it has to be procedural. It has to be methodical. You understand? You have to take it stepwise, know what to look for, know the pitfalls, so that you give a comprehensive and a correct report. So the clinical features: vaginal bleeding, passage of tissue, and the open cervical os. So those are some of the part of the history that formulates an incomplete miscarriage or a miscarriage. So if someone presents with those clinical signs, it should ring at the back of your mind that you are likely dealing with a case of of a of a miscarriage, one or the other, be it complete or incomplete. Also, you must correlate with the information, the knowledge that your referring clinician and the patient is giving you. So complete miscarriage. Ultrasound findings in empty uterus, thin endometrium without retained products of conception. So there should not be any. Don't just call everything a miscarriage before there's a confirmation that someone was pregnant before. So someone might just bleed because of other causes. It could be fibroids, it could be arteriovenous malformations, it could be polyps, it could be hormonal imbalances. It could be anything. It could be abnormal periods as well. So it doesn't mean when someone's bleeding is a miscarriage. So you have to also take into cognizance the history of where is the patient coming from. Was the pregnancy test done prior, and what were the findings? So clinical history usually includes complete passage of pregnancy tissue. So now, pregnancy of unknown location, PUL. Ultrasound findings: positive pregnancy test, no intrauterine pregnancy is noted, no definitive ectopic pregnancy is noted. So it requires serial beta HCG, repeat ultrasound in 48 or 72 hours. So if you don't see any sign of pregnancy, if someone is testing positive for the pregnancy, they warrant to be a transitional period where you call that a pregnancy of unknown origin. So the pregnancy of unknown origin is a transitional term, after which the answer will be found. Either someone was not pregnant at all, or it was an ectopic, or it was just an early pregnancy that was to develop in the normal endometrial cavity. So you must understand those things. Don't just rush to say that there's no pregnancy and then go. What about if it's too early for you to visualize it on ultrasound? And then you send someone say they are not pregnant, they go and they take these other drugs and all that, saying that thing that they're not pregnant. So do not be a risk practitioner, please. So evaluate for complications. Always assess for subchorionic hematoma, free pelvic fluid, adnexia masses, retained products of conception, and signs of ectopic pregnancy. So, guys, this is your Bible. Please, when you're doing your ultrasound scan, the first trimester scan, you must evaluate those signs of complications. Is there any subchorionic hematoma? Yes or no? And you localize it. Is there free pelvic fluid, be it caused by inflammation, be it caused by rupture of ectopic pregnancy or anything? So you must take note of that. Are there adnexal masses? To quantify them. How many are they? Localize them. You understand? How big are they? Are they competing for space with the baby? So there's a lot of things that is involved to give a good report and also to save a pregnancy until the pregnancy delivered. So retain the products of conception if they are there. Then signs of ectopic pregnancy, you also have to take note of those. So now, this is a simplified ultrasound flowchart of the events or that ought to be done or that ought to be followed in that hierarchy or in that order. So now the first thing is positive pregnancy test. Is an intrauterine gestation sex seen? Yes or no? is the embryo visible? If no, pregnancy of unknown location. Embryo visible, yes or no? Is there heartbeat? Then embryo is absent. So mean sac diameter is above 25 millimeters. What does it entail? This is what? An embryonic pregnancy. So if that heartbeat is present, yes, so that's a viable pregnancy, which is very normal. If there's no heartbeat, so what are we saying? The crown rumble length is above or equal to 7 millimeters. That means what? It means that's a missed abortion. Yes, early pregnancy failure. No, repeat scan in 7 to 14 days. I repeat myself again. Look at this flow chart. Let us analyze it together. Let's do it stepwise like this. Pregnancy test is done. Is an intrauterine pregnancy or gestational 16? Is an intrauterine gestational 16? Yes or no? Pregnancy test positive. Is an intrauterine gestational 16? Now we are answering this using ultrasound. Yes, is there. Is the embryo visible? Yes or no? Is the heartbeat present? Yes or no? Is the crown rumble above or equal to 7 millimeters? Yes or no? So you see, these are the questions that you have to flow, and you will be answering. If you master this flow chart, it will be very easy for you to do the sequence of an ultrasound first trimester ultrasound scan. So it's like that. You have to follow it like that. If you miss any of these steps, guys, you are going to make a very dangerous assumption. Doing an obstetric scan, it sounds like something that is very easy. I checked the uterus, there's nothing innocent. I sent the patient away, there's nothing. Oh, I saw the patient, it's a missed abortion, or it's a blighted ovum, innocent. Maybe it did not make an extra effort. The fetus, the embryo is on the other end of the gestational sac, then you couldn't see it, or the probe angulation, or you didn't use the transvaginal, you understand? So there are many confoundings. So you must be very careful when you are doing this. So this is fundamental. This is your Bible, guys. Let me repeat it again for the third time, and I need you to repeat it over and over again. So this is the sequence how you do a first trimester ultrasound scan. The other mistake that most of these people do, they come to the department without a pregnancy test. So it's not good for the referring clinic. Just send the patient without testing the pregnancy. It's a protocol. They have to do that. So that if they come with a pregnancy result, they say that I have tested positive. Then you start from there. Then these are the questions that you are going to answer the ultrasound. Is an intrauterine gestational sac seen? Yes or no? If no, then it's a pregnancy of unknown location. You don't know where the pregnancy is, but it was someone says it positive, but the pregnancy can't see it. So yes, if the gestational sac is there, is the embryo visible? Yes or no? If not visible, then what does it mean? Is a mean sac diameter above or equal to 25 millimeters? If it's above and there's no visible embryo, what does it mean? It means this is likely to be what? A blighted ovum, an embryonic pregnancy. Then, if the heartbeat is, the baby is visible, is there heartbeat? Yes or no? If there's heartbeat, we are fine. That's a viable pregnancy. If there's no heartbeat, then is the crown rumble length above 7 equal to 7 millimeters? Yes or no? If yes, that's an early pregnancy failure. If no, repeat scan in 7 to 14 days. Ladies and gentlemen, I have done my part. I have done my part. I have given you the Bible. It's up to you to read the verses and the chapters when you deliver this to your patients so that you can serve a patient and you can become the ethical professional in your field and in your area, in your country, and in the department where you are working. Thank you so much. Don't forget to subscribe to our channel and also notify others so that we produce the caliber of health cadres who are not just there for money, but who are there to save a patient. Thank you so much.
Hello, ladies and gentlemen, how are you? So, in this presentation, I'm going to talk about what is called the anomaly scan or the detailed scan that is done, or the anatomy scan that is done mostly or traditionally from 20 to 23 weeks of pregnancy. Some they do it from 18 weeks to 23 weeks during that period. So, during this type of scan, I want to go through what we look at when we're doing a detailed ultrasound scan. So, I need you to follow, then we'll see how it is done. So if you look here, you can see here that's the penis there. So this is a male. You can see the male genitalia there. And so this is the genitalia. So we can determine the gender at this stage. These are the legs of the baby. This black one is the water or the amniotic fluid around the baby. So what we have here, that's the placenta there. So you can see the legs of the baby, they are crossing each other there. And you can see the foot there. You can see the tibia and fibula there, and the knee joint. So you can see the foot there, nicely there, the foot there, the foot there. So that's the heart there, that's the heart. This is the heart of the baby, that's the heart. So you can see the two tibia and fibula there, the bones nicely of the leg. Then you can see the baby is moving, you can see that the baby is alive and it's moving. You can see the foot there, you can see the toes. You can see the foot there and the toes nicely there, nicely demonstrated there. You can see the movements of the fetus. So you can see the heart. That's the heart there. You can see here that's the stomach bubble, the black spot there that we have. This one is the spine in transverse. This is one of the ribs. This is the umbilical vein that we have there. That's the stomach bubble that we have there. That's the stomach bubble. So you can see here the movement. The baby is moving. You can see the baby is moving. You can see the legs there. They are changing the positions. So you can see here, this is the wall of the uterus. This is the wall of the uterus. And now we are checking the uterine arteries around the bladder, on either side of the bladder, same there. So you can see the movement there. That's the spine of the baby. That's the heart. That's the heart that we have there. So that's the spine. You can see that the spine is okay. There are no spinal bifidus or any abnormalities of the spine, as you can see there. You can see the heart. So here the baby is facing down. That's the head that you are seeing there. These are the bumps. The legs are here and the hands are coming there. You can see how it is moving. So you can actually see that the heart is within the chest of the baby. Now the baby is turned. Now it's facing up. You can see the eyes of the baby there. The eyes of the baby. You can see the eyes. Look at the eyes. These ones are the eyes. So you can see the hands. The hands of the baby. Those are the hands. Those are the hands. Those are the hands. This is spinal cord. This is the umbilical cord for the baby. That's the umbilical cord. You can see the baby wanted to suck his thumb. This is the penis. It's about to suck the thumb. It stopped. So you see here, it's a male, it's a boy. That's how we determine the fetal gender. So you can nicely see it in the second trimester like that. So you see the foot there, the foot there. So you can see I have zoomed this. This is the fetal brains. This is inside the fetal brain. So this is the cerebellum. This is the cerebellum. And we do have got the cisterna magna there. We do have got the cisterna magna there. And then there's this part of the brain. So you can see here what we have there. So that's the blood that's flowing within the heart of the baby. So there's blood flow in the heart of the baby. You can see nicely there. And then if we come again here, you can visualize the legs again. You can see they are straight, so there's no sign of rickets. They are very straight there. So if we come again, this is the transverse section of the abdomen. That's the fetal stomach. The stomach bubble, the stomach is there. There's the fetal stomach there. So I think it's making sense. These three dots there, that's the spinal cord in transverse, like we're cutting it. Check again. There, that's where our spine is. So if you look, you can see that there are some movements. The babe is in a world of its own. The fetus is in a world of its own. So that's the heart. See the heart there. That's the waveform of the heart. Again, you can see here the thalami and the cavum septum pellucidum there. The thalami, the cavum septum pellucidum. Those are the landmarks that we use to measure the biparietal diameter in our head circumference for the baby. So we use those landmarks. So you can see that the brains are nice. There is no fluid there. There's no sign of hydrocephalus in the head of the fetus. There's no sonographic sign of hydrocephalus. So if we check again, going down deep, so there, you can see the sphenoid bone is also fine. So the baby is turned. Again, these are the legs of the baby. Those are the legs. Those are the legs. So you can see now. You can see now the foot again. The foot is looking much better there. The toes, look at the little toes. Little toes there. So you can see how the baby is excited there in a world of its own. See the toes, that's the foot. So you can see the toes, we can see the abnormalities of the foot as well. Okay, both the feet are there. You can see it again. There it is, there it is, there it is, there it is, there it is. So I hope you are appreciating where we are coming from. So this is the anomaly scan. We are checking literally the organs to see if everything is developed well. So it's an extra effort that you have to take to make sure that you don't miss certain pathologies. Or some pathologies, they are life-threatening. Some pathologies, the baby can live with. So we need to rule out those abnormalities that we plan for management accordingly. That's our placenta there. You see, that's how placenta appear like on ultrasound. That's the placenta there. That's the placenta there. That's the placenta. Okay, so you see the hand now. The hand there, you see those fingers 1, 2, 3, 4, 5. So those are the fingers. So the fingers are there, and there are 5. So you see them again. You see them again. You see them again. Those are the fingers. This is the end there. That's the end, the radius and the ulna. There we have the hands, and you can see the joints. This is the spine, the neck. So you put color there, and you see this is the face now of the baby. This is the lips. This is the nose. This is the nose. You can see the nose there. The nose of the fetus. Those are the nose. So see there. Those are the lip. That's the upper lip. That's the upper lip. The lower lip. That's the mouth of the baby. That's the heart there. So that's the chin there. That's the chin. Again, if you look here, this is the upper lips. The upper lips. The upper lips there. The upper lips there. The upper lips. The upper lips there. The upper lips. You can see now. This is the whole length of the baby there. The whole length of this is the face. You can see the nasal bone. The eye. You can see the eyes there. You can see here. Okay, you can look at the eyes. Those are the eyes there. The eyes there. You can see the eye is wide open. Those are the hands. See the eyes. See the eyes there. Look at the eyes. So here you can see how the baby is moving. You see how it is coiling itself. You see how it is enjoying itself in a world of its own. Look at that. This is amazing. See, this is creation. Look at how it is flexing itself. This is amazing. This is God's creation. You can see there. You can see this is the hip bones, the placenta on color Doppler there. You can see that the baby or the fetus is enjoying the whole session as we are doing the normal scan. Look at the face. Look at that. That's the face of the baby. This is the uterine artery. That's how we measure the right uterine artery to rule out preeclampsia. That's the uterine artery there. That's the uterine artery. That's the uterine artery. This is the other one. You can see how this is when it crosses the external iliac. So this is the cervix. So you can see we are accessing the cervix like that. This is the bladder of the baby there. That's the blood of the mother. Sorry. So, ladies and gentlemen, this brings us to the end of this session. So you can see that the baby is having a gestational age of 21 weeks and 4 days, and the expected delivery is on the 20th of November 2026. So these are the other parameters that we then measure, but the primary business of doing an anomal scan is to check if all the organs are well developed and if there are no abnormalities. Thank you so much. So we now have a playlist in our channel which we call the pregnancy library. So we update it time and again. Watch for those, and then you'll see a lot of obstetrics pregnancy sonars. We'll be uploading time and again. Thank you so much. The heart formulates the lifeline of the fetus. So without talking about the heart, we are not doing anything when it comes to ultrasound imaging. So now, it is prudent or it's fundamental that every person who does ultrasound scans in one way or the other must localize the heart, know how to measure the heart rate, and have a basic understanding of the anatomy of the heart, so that you can ascertain or make sure that the baby is alive, and also there are no obvious structural abnormalities that can hinder the pregnancy or the its progression. So here we've got the heart there. So that's the fetal heart. You can see here. You can see the fetal heart there. That's the fetal heart. That's the fetal heart. So you can see this is the left ventricle, and then you can see the right ventricle there. So you must know the structure of the heart for you to be able to perform a very good ultrasound fetal heart or echo. So you can see here, you can see the aorta there. That is the aorta there. So on color Doppler, you can see that the flow of blood inside the fetal heart. So you must be checking nicely and closely for any structural defects, be it shunts or missing valves, missing ventricles. So you know that the heart has got 4 chambers. So you see, if you put color, you can see the arc of the aorta. That's the aorta that is going there, and the blue one, that's the inferior vena cava. So you must be very, very meticulous, because the fetal heart is one of those things which is not so obvious and not so easy to do. Not most people are very confident of doing fetal echoes. So ideally, when you're doing a fetal heart or a fetal echo, you must make sure that you zoom the image so that you can have an appreciation of the chambers, the greater vessels, and then the outlets, and then the valves. So you must make sure that you put everything into picture, so that you don't miss any abnormalities or any defects. So the other thing, you must make sure that the heart is within the chest. You see, this is the abdomen there, this is the diaphragm there, that's the stomach bubble. So you see that our heart is localized within the chest in the IVC, that's the inferior vena cava there. So you can have a heart that would be at an ectopic site, what we call an ectopia cordis. So do not just scan without localizing anatomy. Localizing anatomy formulates one of the fundamental skills that you have to acquire when you want to be a competent sonographer, or someone who can be confident in your practice. So this is how you can zoom your heart nicely and check all the chambers. Remember, measuring the heart is not easy because we are looking at two moving targets that you have to beat. The fetus will be moving, the heart also is moving. So you must be very vigilant, very patient, very meticulous so that you don't miss obvious pathologies of the heart. Also, during that time when I check in the heart, you also have to check the lungs or the fetal chest to see if there are no structural abnormalities. So this is a continuation of part of the fetal anatomy or anomaly assessment that I was talking about. So you must be very careful because it is very easy to miss. I also do miss these fetal echo abnormalities. Some of them they are too silent and you can obviously overlook them and miss them. So I need you to understand and appreciate the skills that you can use. You have a good resolution machine, zoom the target area so that everything comes into picture. Then you can do your sonar nicely. So I hope everything is making sense. I hope everything is making sense. If you have got questions or you have got a machine that you don't trust, because some people they fight their own machines. If you don't trust your own machine, it is very pertinent that you can consult me. Then I will show you how to best utilize your machine to get the best results. I hope you are learning. I hope you are taking notes. So let's meet again in the next episode of our learning series. Thank you so much.
Hello everyone, how are you doing? So in this presentation we are going to discuss first on the early intrauterine pregnancy, the signs. Then I will go to the quiz questions, 10 quiz questions, where you are supposed to choose the correct responses, write in the comment sections. Then after, we are going to have the next session where we discuss the answers. So it's very critical for you to test yourself and your skills so that you see how you are coping or how competent you are. So now, the gestational sac is the first sign of pregnancy. So the key features of a gestational sac is anechoic, black, round, it's oval structure within the uterus. So the yolk sac is the first structure seen inside the gestational sac between 5 to 6 weeks. Sorry. So the decidual reaction sign, which is the bright echogenic rim surrounding the sac. So this is what we call the decidual reaction that we see. It confirms pregnancy, and this is the yolk sac that you are seeing there. That's the yolk sac that we have there. So that's the uterus. So with the gestational sac there, that is the gestational sac. So this is the gestational sac that we have there. That's the gestational sac, and then the yolk sac there. So the next step, yolk sac appears at 5 to 6 weeks. Then the embryo will develop. Then the confirmation, presence of a gestational sac confirms an intrauterine pregnancy. So the normal size, gestational sac, 2 to 3 millimeters, visible at 4.5 weeks. So it's on the calendar, it can be noted from 4.5 to 5.5 weeks. So this is the decidual reaction that we're talking about. So this is the gestational sac. So our quiz sessions are going to be derived from the first trimester. So your understanding of the signs of an early pregnancy are fundamental or key for you to answer the questions which are following. So let's go to question number 1. Which structure is the first to be seen within the gestational sac? A. Embryo. B. Amniotic sac. C. The yolk sac. D. The placenta. So which structure is the first to be seen within the gestational sac? Embryo, the amniotic sac, the yolk sac, or the placenta? So write the answer in the comment section, then let's discuss. Then after, I'm going to give you the answers. Question number 2. At approximately what mean gestational sac diameter should an embryo normally be visible on transvaginal ultrasound? A. 10 millimeter, B. 15 millimeters, C. 25 millimeters, then D. 35 millimeters. Which one is the correct response? At approximately what gestational sac diameter, MSD, should an embryo normally be visible on transvaginal ultrasound? A. 10 millimeters, B. 15 millimeters, C. 25 millimeters, then D. 35 millimeters. Question number 3. A crown rump length measures 8 millimeters, but no cardiac activity is seen. What is the most likely diagnosis? A. Normal early pregnancy. B. Missed miscarriage, early pregnancy loss. C. Pregnancy of unknown location. D. The molar pregnancy. A crown rump length measures 8 millimeters, but no cardiac activity is seen. What is the most likely diagnosis? A. Normal early pregnancy. B. Missed miscarriage, early pregnancy loss. C. Pregnancy of unknown location. D. Molar pregnancy. Question number 4. Which ultrasound finding is most suggestive of an ectopic pregnancy? A. Intrauterine gestational sac with a yolk sac. B. Adnexal gestational sac containing a yolk sac or embryo. C. Thickened endometrium. D. The corpus luteum cyst. Which ultrasound finding is most suggestive of an ectopic pregnancy? A. Intrauterine gestational sac with a yolk sac. B. Adnexal gestational sac containing a yolk sac or embryo. C. Thickened endometrium. D. Corpus luteum cyst. Question number 5. Which measurement provides the most accurate estimate of gestational age during the first trimester? Which measurement provides the most accurate estimate of gestational age during the first trimester? A. The biparietal diameter. B. The femur length. C. The crown rump length. D. The head circumference. Which measurement provides the most accurate estimate of gestational age during the first trimester? A. Biparietal diameter. B. Femur length. C. Crown rump length. D. Head circumference. Question number 6. Increased knockout translucency is associated with which condition? A. Placenta previa. B. Down syndrome trisomy 21. C. Polyhydramnios. Then D. Oligohydramnios. Again, increased knockout translucency is associated with which condition? A. Placenta previa. B. Down syndrome trisomy 21. C. Polyhydramnios. Then D. Oligohydramnios. Question number 7. Which ultrasound sign is classically associated with a molar pregnancy? Which ultrasound sign is classically associated with a molar pregnancy? A. Double decidual sex sign. B. Snowstorm appearance. C. Banana sign. D. The lemon sign. Which ultrasound sign is classically associated with a molar pregnancy? A. Double decidual reaction sign. B. Snowstorm appearance. C. Banana sign. D. The lemon sign. So let's discuss. Please attempt, that's the way to learning. Learning is not about you getting answers passively. If you participate, you gain more. So Please try to give the answers in the comment section, then we can take it together, then we discuss more. Which finding confirms fetal viability in the first trimester? A. Thick endometrium. B. Gestational sac. C. Yolk sac. D. Embryonic cardiac activity. Question number 8. Which finding confirms fetal viability in the first trimester? A. Thick endometrium. B. Gestational sac. C. Yolk sac. D. Embryonic cardiac activity. Which one confirms viability in the first trimester? Question number 9. Which condition normally produces the ring of fire appearance on Doppler? Which condition commonly produces the ring of fire appearance on Doppler? A. Placenta previa. B. Corpus luteum cyst. C. Endometrial polyp. D. Uterine fibroid. Which condition commonly produces the ring of fire appearance on a Doppler? A. Placenta previa. B. Corpus luteum cyst. C. Endometrial polyp. D. Uterine fibroid. Which one is the best option there? Which condition commonly produces the ring of fire appearance on Doppler? Placenta previa, corpus luteum cyst, endometrial polyp, or uterine fibroid? Question number 10. Which structure develops into the fetal side of the placenta? Which structure develops into the fetal side of the placenta? A. Decidual basalis. B. Chorion frondosum. C. Yolk sac. D. Amnion. Once again, which structure develops into the fetal side of the placenta? Decidual basalis, chorion frondosum, the yolk sac, or the amnion? So, ladies and gentlemen, these are our 10 quiz questions. So, try to attempt them all. Write your answers in the comment section, then we discuss. Then after, I will give you the answers for self-assessment. Do not cheat yourself. Let's learn. These things, they appear like they are obvious things, but they cannot be so obvious if you do them diligently. You can see that at times you overlook certain things that you can realize that learning is now taking place. Thank you so much. All the best in the quiz session. Enjoy the rest of your day. Don't forget to like and share this quiz session with your colleagues so that they also attempt. Bye. Let's meet when we discuss the answers.
People of the internet, gather here. Now, I'm going to show you how a fetal male genitalia or the scrotum appear like on 4D ultrasound. So this is another way of gender determination when you're doing your second trimester or another trimester fetal determination using ultrasound. So I'm going to show you both how it appear like on the 4D and also on the 2D, the standard mode that you guys you do. So let's start. So you look here. So you can see here what you are seeing here. Those are the testicles. You can see the balls there. You can see the balls there. Those are the balls there. These are the fetal bumps. The fetal bumps there. The fetal, and the balls there. The testicles there. The testicles. So this is the septum that is dividing the testicles like that. You can see there. These are the testicles. The fetal bumps. The bumps. The bumps. These are the feet there. The feet. So you can see how nicely doing this is the foot. You can see the foot of the fetus there. You can see it now. You can see it here. You can see the balls there, the balls there, the balls there. So now until you can see, look at the feet also. You can see the feet there, the toes. Look at the toes. Look at the toes. This is the umbilical cord there. Guys, this is so fascinating. This is fascinating. You see, I did this case today, and you can see the foot there nicely, the toes, and you can see the bones of the foot nicely there. You can see the heart there. You can see the arc of the aorta, the aortic arc nicely there. and the spine. You can see the spine at the back. So these are part of the skills, guys, you have to understand or master. Uh, Fetal gender determination is one of the key things that can actually make the expecting parents or very excited. So if you master how to identify the gender, you see here on 2D, that's the penis there and the testicles. So these are the 2D acquisition. That's our 2D acquisition, the brightest mode. So you can see the turtle sign there. That's our turtle sign. That's the total turtle sign there. That's the turtle sign. Yes, the penis. And you can see the sex there, the sex is there. So you can see this gender is very much well demonstrated and well displayed. There are no two ways about that. So some of the things that can make you guys lose credit as a practitioner is when you falsify things. This is the bladder of the fetus. So if you tell your your patients your patient or a patient that the opposite gender, and then when they deliver, they can come back to you or they discredit your practice. So you must make sure that you do your homework properly before you divulge the gender. So these are some of the emotional moments that an expecting couple can go through or the first time the gender is revealed to them. Some they can be very much excited to say that we've stayed for long without a boy fetus, and finally the heavens are smiling on us. Uh, but some could be saying, I already have 7 boys. Now this is the 8th boy. We've been trying to make a girl ever since. So don't take gender reveal as a lightly thing. It forms one of the fundamental fabrics of obstetric gynecology imaging. So if you know how to distinguish or to differentiate a male and a fit and a male female and a male gender on ultrasound, that is a good step in career development or in terms of building your own reputation. We have got reputations to protect as practitioners above and beyond doing justice to the patients who are paying us their monies. I want you to look here, guys. You see this one, the cord is coming closer to the scrotum there. So these are some of the misleading things where gender can be mistaken. You see this cord there. If you don't look closely, you're going to think that this is a vagina opening there. Then you're going to say that this is a girl. So I recommend that when you're doing your verification of the gender, try to do it in a different plane. This is the blood of the baby. You can see now how nicely it is, and the penis is there, and the scrotum. So I need you guys to do due diligence when it comes to fetal gender determination. Make sure that these are the little things that can actually destroy your reputation for a very long time, if not for the rest of your career, especially when you are living in a community where everyone knows you, where you are known. So you've got a reputation to protect. So in their corridors, they will be gossiping that this is the person who missed the gender and they made me to buy the clothes for the girl or for the boy. So don't embarrass yourself. Take your time. So you see, I've used these two modes. I have confirmed in both 2D and 4D that indeed it's a boy. So this is continuation of a fetal anomaly scan. If you do that, you complement the anomaly scan or the anatomy scan, and then the parents can bond more with their unborn baby. I have the case where one guy was saying that I was born with the 3 sisters, I'm the only boy. So now it was his turn. So he was carrying a boy, and then he was saying now that we have a family representative, the next chief. So you see, cultures in the traditions, they were attachments towards a gender reveal. So I need you guys to take this seriously so that we do justice to the community or the communities which we serve in our respective departments. I thank you very much. Don't forget to share this educational content and also subscribe to our channel. Invite your friends also to watch our channel. Thank you so much. Enjoy the rest of your day.
Hello, good people. How are you? So in this presentation, let me talk about the paranoia of early pregnancy. Early pregnancy is associated with a lot of uncertainties, a lot of risk, a lot of fears. There's a lot will be going on. So that's the time during which someone needs to be quite sure that they are pregnant or not. They need to localize the pregnancy. Is it in the normal position? They need to make sure that there are no other disturbances like fibroids, other structural abnormalities that can also affect the pregnancy. So now, let's talk about this case that I did at our department. So what you're seeing here is a very early pregnancy at around 6 weeks and 5 days. So you can see the fetus there. So here were the fetus. So this patient now came to our department. She's having a lower abdominal pain, and there's a fear of an ectopic pregnancy. That was the main worry from the referring clinician. So now I did the sonar, and here are the findings. So you can see we are seeing a mass there in the right adnexia. You can see the right adnexal mass there. There's the right. These are the bowels which are moving there, but there's a free fluid around the mass. So, ladies and gentlemen, what do you think? What do you think that mass is? What do you think that mass is? What is that mass? So you can see there's a right adnexal mass. So this is the right adnexal mass there. So now what we have, that's the blood flow in the heart. What is this mass, guys? We got a right adnexal mass there. The baby looks fine. See the yolk sac there, and then you can see the amniotic sac there. You can see the amniotic sac there, which is very nice. So this is the fetal head, the rhombencephalon of the baby there. What is this mass that we are seeing here? This is the mass of concern. So what is that? What is that? What is that? Who can guess it right? Who can guess it right? Look on the Doppler, you see it's enhancing there on the peripheries, like that. What is that mass? That's the right adnexal mass there. So on a good note, you can see that the fetus is alive and it's in the normal position, intrauterine. There is no sign of an ectopic, but what is that now? What is this thing that you're seeing there? That is the main concern of this sonar. So if you have got an idea of what that could be, please let's share, let's talk on the on under the comment sections. So I'm excited that the baby is alive, and the heart, you can see the heart there. You can see here the vitelline duct there, and then right around the uterus. The uterus looks clean though there are no masses, but we have got this. What is that with the fluid there? So guys, according to my own assessment, let me explain what I think this is. So this is the right over there, because that's the only, you see it's right over there, and then you can see that it's edematous, and then there's peri-ovarian effusion. So that morphology is consistent with an inflammatory process or inflammation of the ovary itself. It's edematous and it's hyperperfused. So what we have here, that's the infusion there. You can see the fluid around the ovary. So guys, this is inflammation of the ovary. This is ovaritis. So this is ovaritis. So ovaritis is, in this case, is the culprit. So the ovary is inflamed. That's why this patient is having the lower abdominal pain that she is having. So if you are not so careful, you are going to just concentrate on the fetus and then ignore whatever is going on here. So there is an inflammation of the ovary that is happening there. The milieu of the pregnancy itself, or the internal part of the pregnancy, is fine. The internal part of the uterus is okay. There is nothing abnormal there. There are no uterine masses, as you can see. There's a singleton baby. There are no extrauterine fetus as well. And the other nexus structures are fine. You can see the peristalsis there, the movement of food in the bowels. So you can see it nicely there. So the only culprit that we have here is the ovary that is edematous with an effusion. So this is ovaritis. That's ovaritis. You see the peristalsis there. You can see peristalsis nicely there. So that's my thinking. That's my line of thinking. If you have any other suggestions or other contributions or other suggestions pertaining to this ultrasound, you can share. But this is the beauty of ultrasound. You see, you can see nicely the early embryo there. So the early embryo, the limb buds are not yet visible, but the limb bud, the embryo is developing. The head is there. You can see it's developing nicely. So the main worry of pelvic infections, they can affect the fetus as well. So when there's an infection in the pelvis, it has to be taken care of way before it affects the fetus. So you can also have what are called touch infections, which can actually cause a lot of problems to the growing embryo there. So when one is pregnant, they must be very careful when these infections start to manifest like that, because you can see there. So this infection can spread and affect the fetus in due time. So it has to be managed. I think this brings us to the end of our case. This is also how you measure the heart rate. You see, this is the air mode. So in the early stages, we don't use pulse Doppler because the embryo is still very delicate. So we use motion mode. Yeah. So if the signals are not well, you can put color and then you use the air mode. Then you can visualize the waveform very nicely, like in our case. So we could pick the heart rate. You could measure the heart rate in those early stages. Ladies and gentlemen, life is too precious in early stages, as you can see. Life is too precious, but we don't need these invaders. So if you miss the invaders, it means you're also contributing to the challenges that the pregnancy or the future pregnancy complications that can come. So you have a duty to make sure that you make a correct diagnosis and detect these problems early. Thank you so much. Any questions, please feel free to get in touch with me. At the same time, I also need your contributions under the comment section. Let's build the community together. Thank you so much. Enjoy your day.
Hello, good people. How are you? So today we have a case that we want to tackle here. There is also an illusion that we've seen in this fetal case, so I need you to pay particular attention to it, then we will discuss it or dissect it. So what we have here is this is the urinary bladder. So you can see these are the fetal bowels. You can see they are echogenic. They are echogenic fetal bowels. The echogenic fetal bowels. So you can see that these fetal bowels are echogenic there. That's the heart of the fetus there. That's the heart of the fetus there. So echogenic fetal bowel is an ultrasound finding in which the fetal bowel appears bright. So if the fetal bowels appear bright like that, that is called echogenic fetal bowel, and then it will be a normal variant, but sometimes it can be an indicator of chromosomal abnormalities, trisomy 21, most common. But in some cases, it might just be a normal variant. So it can also imply that there is some congenital infection that is taking place, like a congenital cytomegalovirus infections. They can also cause that. Then congenital toxoplasmosis, congenital parvovirus B19 infections can also cause fetal echogenic bowels. Then we can also have meconial ileus, bowel obstruction, meconial peritonitis, intestinal ileus, you have volvulus, bowel perforation, and some of the things that can also cause an echogenic bowel. So when you're doing an ultrasound scan, then you see this echogenic fetal bowel. You must always comment on that. Do not ignore it. It can also imply that there is an intra-amniotic bleeding, especially if the mother had vaginal bleeding, subchorionic hemorrhages, placenta bleeding. The fetus can swallow the blood, then it can appear like that. So persistent echogenic bowel can also be a challenge because it can cause UGR as well. So you have to report on it. Don't ignore this when you see it, but that's not my main focus or my main challenge for the day. I need to show you something that is a greatest masquerade there. There is something that is coming that I need you to appreciate and see. Look at this. What is this, guys? Look at this. This is the placenta there. What we have here. So there's a cyst with a septation there. This thing is appearing. You see, if we do this, it appears like it's coming from the fetal head. Look at it. That item there. That item there. What is that? So it looks like here it looks like it's an encephalocele. Look at it, but here it appears like it's coming from the placenta. So which is which? So this is one of the greatest challenges. You see, the fetal head is here and the lesion is there. It's coming there. What is that? What is that? You see, this is the placenta here. It looks like it's attached to the fetal head, but in this orientation, it's not attached to the fetal head. So look, but if you put it like in transverse like that, you can see now that this lesion there is not even attached to the fetal head. So this is a distinctive placental cyst. So this is a placental cyst. You can see there the fetal head is here, and you can appreciate it there. So if you rush this sonar, you're going to mistake this for an encephalocele. You look at it from there. It has got the morphology or appearance of an encephalocele, but it's not an encephalocele. So, ladies and gentlemen, when you're doing these ultrasound scans, you must be very, very careful. Pay particular attention to all the detail that you're seeing there. So, echogenic fetal bowel, that's the first thing that you've seen there. Then the heart is fine. Then there's this thing. So, if you are not careful, you are going to mistake this one for a hygroma, or you are going to mistake this one for an encephalocele. But if you are taking, you see like this, it looks like it's coming from the fetal brain there. Look at, you see how it is appearing like. It looks like, but here you can nicely see that it's originating from the placenta. So there's some solid internal components there. Maybe it's just some hemorrhage which are just inside. This looks like fibrin strands, so this could just be a normal hemorrhage. Then, yeah, you can see that there are some internal echoes as well inside the amniotic fluid. So internal echoes in the amniotic fluid, they symbolize venex caseosa, which is the skin peeling from the fetus. So those are some of the things that we have to make peace with. If you don't make peace with these things, they are going to haunt you in your practice of medical ultrasound. So fetal ultrasound is one of those things where you have to look at a lot of issues. You must carefully look at the placenta. You also have to look at the um, attachment with the placenta itself. Is it well coupled? Is it not a placenta abruption? Those are some of the things. The attachment of the umbilical cord as well. You must see, is it attaching at the correct position? So the umbilical cord itself, if it is not thickened, so there's a lot of work that is involved. There's a lot of work that is involved. So I don't need you to rush these things. You see, the placenta is attaching here just adjacent to the placental cyst that we have here. So I particularly highlighted this case because it's one of those things. Initially, when I saw this, I was thinking that maybe it's a encephalocele, but after due diligence, you can see that it's not originating from there, from the fetus. So, ladies and gentlemen, I thank you so much if you are paying particular attention to this neat and smart detail. Otherwise, we are going to be very, very horrible practitioners. Don't forget to turn on the notification button and then also subscribe to our channel. Let's keep on growing the community so that we get engaged. If we grow big, it means a lot of people are going to come up with the different ideas, then we can learn from all angles. If you have got any questions, feel free to get in touch with me. My name is Last. Then I can assist you in any capacity. You can type the comments in the comment section. You can also check for my email and the website. Then last at chitumba@outlook.com. Then you can send me a message. Thank you so much.
Sometimes there's a war, there's conflict between religion and science, spirituality and science. They conflict at times. That brings a lot of challenges to the practice of medicine in general. It also brings challenges to the practice of medical ultrasound. So, let me present to you one of these emotional cases that I did at my department. So we were this couple. So this couple, they wanted a girl child. They've got 6 boys already. So they are looking for a girl. So they went to church. So their pastor, their prophet, they said now this one is a it's a girl. So they that attachment. Then they came to for the sauna with that hype, very excited about everything that was going on. The expectation of having a girl child for the first time in their life, it was very temperamental. They were very, very excited. So, science and spirituality at times, they conflict or they do fight. So now, I did the sauna, and, this baby, it didn't want to hide anything. So, they were very much convinced with what the man of God said. So now, let's review the gender together, and then you can share the emotion and appreciate what this couple went through. You see, these are the testicles, and this is the penis there. So even a novice of medical ultrasound can easily tell that these are the balls and this is the penis. You know, those are the emotional moments when you have to pay your patients contrary to what they believe in or to what they think is the reality. They've got spiritual attachment to what the man of God told them. So you see, and it's a boy, it's a boy. So I don't know, guys. Departments, do you also encounter such type of uh, emotional experiences where a patient already has got a predetermined outcome of everything? Then what they need from you is just you rubber stamping that whatever they have from wherever they found it. So this is one of those cases. So we were now in conflict, and to say, you guys, look at that. This is a boy. They denied. They were denying it. They were denying it. I had to show them images from elsewhere to convince them, see the total sign, this was called. Then I had to take them through the whole session, but they were getting disinterested, disengaged. They were disengaging themselves from the whole conversation. So beyond and above the probe, there are things, social issues that we moral issues, emotional issues that we have to handle as practitioners. It's just like you doing a sonar, then you see that maybe the fetus is dead already. So those are some of the issues that comes with the as a package of the practice of medical ultrasound. How do you handle such type of cases? If you were in my shoes, how were you going to handle this kind of a situation? How were you going to handle it? Were you going to just, because their main focus was just for they wanted me to just rubber stamp, you know, everything else to them it was not important. It was irrelevant. So what was relevant for them is for me to just rubber stamp the gender and say that is a girl. You understand? But to the contrary, it's a boy, as you can see there. So how do you handle such issues? Or if you were in my shoes, guys, let's talk. How were you going to handle such a case? Was I going to say that I can't see the gender? Was I going to say that the prophet said the truth? Or was I just going to keep quiet when they just paid their money specifically for the gender confirmation, for the rubber stamping, and to give eulogies and everything to whoever did whatever? You understand? They needed that. They wanted to give the man of God the credit that he deserves. So the honor and the esteem that they had. So the practice of ultrasound has got other attributes that we need to cultivate and that we need to have, besides you knowing the pathology and the anatomy. So it goes beyond the daily attritions and abrasions of you searching for anatomy, identifying pathology, writing the report. But the major issue is the emotional, the psychological issue associated with ultrasound scan and the disclosure of certain information to the patients. How do you do at your practice? Do you disclose such information? Do you keep it yourself? If you keep it yourself, how do they value you? Do they see you as a competent somebody, or they will see that this person is a robot or doesn't know what he's doing? You understand? I don't know. How do you handle such issues? Let's talk. Please do help me. Where in the country where you are working, can you just come under the comment section and say that I'm working in Romania? Then how do we handle such issues? What are the legislation? What is relevant to disclosure issues and all that? And how do we do it at our branch, in our department? To me, it was more like traumatizing. It's like just working against the clock of others. Others are moving in a positive direction. They are going wherever they are and they're working against them. It's quite emotional. It's one of those things. It's very difficult, guys. It sounds as if, when you are not working with patients, it sounds like the ABC is something that's too obvious. But no, those are not obvious. But you know what? I had to go the hard way to show them the images, explain what it means to them. We explain that this is a male, explain and I didn't want to undermine whatever the man of God told them, or the belief what he has done to them previously. You understand? But I had to stick to the scientific way of doing things. This is a machine. That's why you're here. You can see it on your own. You understand? It needs, yeah. So we are still waiting for this baby to be born. Maybe spiritually is going to be a girl. I don't know. Let's start the conversation. I'm ready for the conversation, guys. Let's bring the conversation, then we can elaborate and build upon it. Thank you so much for your time. I need you to share this information so that we can develop a community. Let's develop a community of sonographers where we share our resources and pool knowledge together for the good of our own practice and for the good of the patients. Thank you so much.
Hello, how are you doing? So we have the case here of a young lady with a family history of breast cancer. So this is what we found in the breast. So this is a lesion that we have. It's a hypoechoic as compared to the surrounding breast tissue and heterogeneous lesion, well outlined. You can see that it's wider than it is tall. What do you think this guy is? I need you to also give your views in your comments. So this is the lesion. So on elastography, that's the lesion there. That's the lesion. That's how it is appearing like. So there's no intralesional perfusion. There is no intralesional perfusion, and the lesion has no color flow on Doppler. And the patient started to notice this one last year, and since then it almost relatively maintained its size like that. So she didn't have another sonar. It's only palpation or palpation that she was just feeling the lump. And then so if you look at the other part of the breast, you can see this morphology. What do you call this morphology, guys? What is this? What is that? Is this normal breast? Is this normal? Is this normal breast? I need your views. I also need your views to say what that is. Is that normal breast or what? Okay. So if you can look at the lesion there, you can see it's hypoechoic. It is hypoechoic as compared to the, if you compare it to the surrounding tissue here, you can see that this is a little bit darker as compared to the surrounding. So this is not fat. And then when you are also checking these lesions for cancer, you must see, compare if they are wider. So this is running along the grains than they are tall. So this is how tall they are. So normally cancerous lesions, they are tall, like they grow against the grains of the normal grains of the like that. So they will be tall like that. And at the same time, they can be irregular with multiple angulations. So you can see a cancer developing like that. But what you can see here, you can see this is well outlined. So our lesion is well outlined there like that. So when a lesion is well outlined like that, it is very much suggestive of a benign process, a benign process. So this morphology highly favors a benign breast mass. So this lady is just a young lady who is 19, and then she has this. So these breast lesions, they normally develop in young ladies. They are the ones who are prone to have these lesions growing. And you see, most people, they just confuse the for cancer, especially the patients, they panic. They think that they already have got cancer. But these lesions, they are non-cancerous and they are called fibroadenomas. So they are called fibroadenomas. So that's a fibroadenoma, 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 adenoma. Have you ever heard about fibroadenomas? Adenoma, that's a adenoma, like that. So that's a fibroadenoma. But there's another lesion or another mass that also resembles a fibroadenoma, which is called a Phyllodes tumor. So a Phyllodes tumor is also a differential to this case. So a Phyllodes tumor like this. So a Phyllodes tumor is also a differential. That's a Phyllodes tumor. Phyllodes tumor. Phyllodes tumor like that. It's also a differential. But the major difference between a Phyllodes tumor and a fibroadenoma is that a fibroadenoma is a rapidly growing lesion. This a Phyllodes tumor, sorry, it's a rapidly growing lesion, whereas this fibroadenoma, it grows gradually. So I said the size of this lesion, since the patient started to feel it, has relatively been constant. So it has not been uh, developing. So, or it has not been increasing. So basically, this is in keeping with what a fibroadenoma. Whereas a villous tumor, it develops rapidly. Maybe someone has got this tumor last month, then this month it has grown by 2 times. It's growing faster. So that's the major distinction between a villous tumor and a fibroadenoma. Plus, villous tumor, they've got um, there are three different types. We have got what is called the benign one, then borderline, and the malignant one. So they've got those three different distinctions. So the villous tumor, that is a benign, or we have characteristics of fibroadenoma like that, and you can also see posterior acoustic enhancement like that, and you won't see flow on Doppler. But there are those ones which are borderline between a benign and a cancerous uh, lesion. They will have features of malignance and beneath it. So you can see a lesion like this, then it will have color flow inside, but it's wider than this toe. It's well outlined, but without color flow. That would be a benign one. Then you have a villous tumor that is now cancerous. That one we have the morphology of cancer. Then you see all the features of cancer manifesting. So that is the major difference between those things. So you must know these are rapidly growing tumors. Then you can also have another morphology. You can also have another morphology that we have to talk about, another morphology there. So let me erase this. So now the other part of the breast, as you've seen there, it is called fibrocystic morphology. So we do have got some areas where there's a lot of fiber, and there's also some cystic spaces. So that is called a fibrocystic breast morphology, or a diffuse cystic mastopathy. Let me show you the morphology that I am talking about on the other part of the breast. So this is elastography. Those who like elastography, I like elastography, so I need to teach you elastography first before I can explain a lot about elastography. Otherwise, most of you will be lost. Then you must know. Yeah, so this is what I was talking about, guys. This is what I'm talking about. This is what I'm talking about. So the area of the breast that is brighter, that's the fibrous tissue, and then you can see there's a cystic spaces. So this morphology, this configuration, this one is what is called fibrocystic breast morphology, or diffuse cystic mastopathy. Diffuse, diffuse, diffuse cystic mastopathy, cystic mastopathy, mastopathy. So that's the morphology that we have there. It's another condition. It's just mostly a variant of the normal breast, and then this type of breast can also present with the pain when with the morphology or configuration like this. So it's called fibrocystic breast or diffuse cystic mastopathy. Ladies and gentlemen, thank you so much for your time. Don't forget to subscribe our channel for more. Enjoy the rest of your day. Thank you. Hello everyone, how are you doing? So today we have the case of a testicular mass. So this mass you can see here, that's the mass. So the referring clinician was suspecting that this could be a testicular abscess. But you can see here, if we put color there, there is perfusion in the left scrotal mass. So there is perfusion there. Though this is masquerading, it is masquerading as the, you can see that it's masquerading as, it's masquerading as the, as fluid. If you don't use color, you can see there it looks like it's fluid. But now when you use color now, you can appreciate that this is a, this is a solid mass, because there is a perfusion in the mass. So guys, what do you think this mass is? What do you think this lesion is? Is it a scrotal abscess, or is it another mass? So this hyperperfusion there, it gives us two possibilities. So the first possibility is that this mass could be malignant lesion. Two, it could be an inflammatory process. An inflammatory process there. So with that swelling, so I need you to give your inputs. So you can see there's blood flow in the mass. There's blood flowing in the mass. So the testicle, the left testicle looks normal. You can see this is the left testicle in the same side. It looks very normal. There is no associated free fluid or hydrocele. There's no hydrocele around the testicle there. So what's your take, guys? What do you think this thing could be? What can this thing be? What can that thing be? You see both the testicles now. You can see the right and the left testicles. They look very okay. They look very okay. The left epididymal head, it looks okay as well. So what is that mass? What's your take? What do you think that mass could be? What do you think that mass could be? And it's extra testicular, as you can see. It's on the scrotal wall. So it's most towards the perineum. So it's between the anus and the scrotum around there, but on the posterior wall of the. So you can see here on power Doppler how this testicle is picking color. You can see there in that one. So they are isovascular. So in structures, you've got almost the same vascularity. We call them isovascular. So these two testicles, they are isovascular, meaning to say that there is no hyperperfusion in the affected testicle there. So what's your take? What do you think this is? What do you think that is? So you can see the perfusion there on the mass. So if you look at the mass here, so you can see that mass is here. It's hypervascular and it's not fluid. Could this be an organizing abscess, or it's a malignant mass? So testicular masses, they should be treated with caution, or scrotal masses, they should be treated with caution, because they could be a sign of malignancy. So what's your take? If I was you, how were you going to comment on this scrotal mass there? Okay, so you see, if you don't scan nicely in the correct position, you are going to feel that this is the testicle itself. But this is not the testicle. It's a very painful left scrotal mass, more on the posterior wall, of the testicle there. Morning. So okay. So, so what's your take? What's your take? What's your take? What's your take? What can that be? What can that be? You can see the characteristic of this mass, the characteristic of that mass. So I need your assistance, guys. I need your tech. I need you to give me your what you think that mass is it so you can see here on color Doppler, so you can see here this color Doppler, this color Doppler there. So if you don't use color initially, you could think that this is a collection of an abscess. So is this an abscess, or it's a testicular mass? If it's a testicular mass, do you think it's benign, or there is a malignant transformation in the mass? So what do you think? Do you think? Give me your take. So you can see again the mass there. What do you think that thing is? What do you think that is? Because if it was an abscess that it was organizing, we should be seeing inflammatory exudate. So there's no sonographic sign of any inflammatory exudate there. So what is that? What is that thing? What is that thing? So I in this case, I think we should just give differentials. But also the other funny part of the thing is this mass is well outlined. So it has got both features of a benign mass and also in maybe it's an adenomatoid tumor. Maybe it's just an adenomatoid tumor because it has got intralesional perfusion at the same time. It is also having features of benignity. It's not invading anywhere. There is no associated inflammatory exudate. So I think a biopsy can resolve this impasse. So I feel biopsy will be the best or the most ideal. So these are some of the most challenging cases that you can come across when you are doing your ultrasound. So in such case, you must give room for differentials. So differentials are always the way to ethical medical practice. So thank you, ladies and gentlemen, for this case. If you have got any other differentials that you feel, please share or type on the comment section. Then we can also learn from you. Thank you so much. Don't forget to subscribe to our channel and share, also comment. Thank you. Hello and welcome. So when they say time is testicle, this is what they mean. Look at this guy. He had pain 2 days back, and today he came to our department with a swollen right scrotum. And look what we saw there. So you see, this is the testicle and the spermatic cord and the head of the epididymis. Everything is just like that. And you can see there's no flow on Doppler. So there's infunction that you're seeing here. You can see those cystic spaces there, and then you can see this hyperechoic structure there. So this is necrosis. So this testicle is dying. Look at the left testicle there. That's a very normal testicle there. So this is a normal testicle. This testicle is died. So what we have here, ladies and gentlemen, is a case of testicular torsion. So if there is testicular torsion and then the condition is not managed within 6 hours, then the testicle will start to die. So you can see that this testicle is died. So this testicle is dead. So that's a dead testicle. So you can relate. Look what we are seeing here. What we are seeing here. So this is a dead testicle. These are infarcts. So you can see there's infarction that's happening there. So you can see that the spermatic cord and the epididyms are just punching up there. They're just punching up there. They're just punching up there. So this testicle is gone. That testicle is gone. This gone is gone is gone gone. This is testicular torsion, and if you look at the scrotum, you can see that the scrotum is also very much thickened. Let me show you how thick the scrotum is. So the scrotum is very thick. So the scrotum is very thick. So that's the thickness of the scrotum. That's the scrotum there, that is very thickened like that. So the scrotum is thick, as you can see there, So delayed management is taken as this far. This is delayed management. So this testicle is gone. So this is what we call a carpet testicle. So when a testicle dies like that, we call it a carpet testicle. So that's the problem that most of our clients, they are not aware that when they start to feel testicular pain, they must quickly go to seek medical attention. Otherwise, the testicle is going to die, like the case that we have. So we with a normal testicle there, that's the right. You can see that there's intratesticular normal perfusion there, a normal microvascular ultrasound. So here there is nothing. So there we have your testicle, and then you don't see the bunching up here on this side of the. There's a bunching up of the spermatic cord and the epididymis, the head of the epididymis, but here is nice. There is nothing like that. So delayed management. So this is just a young man whose future is going to be uncertain if he become reckless again and he loses the other testicle. So you can see nicely now how the scrotum is thickened. The scrotum is thickened. The scrotum is thickened. But the good thing is there's no hydrocele here. So this is mild normal. This is physiological free fluid in the testicle there. So you can see this part of the spermatic cord now is in the front. So you see this part that is presenting there. So it is twisted, and then you can see it's appearing now in the front, as you can see like that. So this is a problem. That's a huge problem there. That's a huge problem there. The spermatic cord and the epididymis are now twisted at the front now. So this testicle, there's nothing that can be done to it. It has to be surgically removed. It has to be surgically removed. You see, I tried to use Doppler to try to see if there's color flow. There's nothing. It's only the artifacts that we have there. It's only those are just artifacts, though that's not blood flow in the testicle there. So there you can see nicely. So these other sports guys, let me show you. Some people, they don't know what infarcts look like on ultrasound. So you see these dark spots, these ones. So that's a sign of death. So this is fluid that is accumulating due to dead tissue. So that's infarction. So that's the first thing that happens after death. You have tissue is no longer having blood supply, so it swells up, becomes edematous, and at the same time you don't see blood flow in it. But after some time, then it shrinks, and then that process is called necrosis. So I've seen segmental areas which with necrosis. Let me do this again. So look here now, or let me show you the necrosis. So what we have now, this is necrosis. You see this echogenic area there, that's necrosis. So this is the final stage of death. Beyond redemption, the testicle is dying. So initially it swells, then the water will be absorbed, and then it hardens, it shrinks. So this hardening is the infarction that I'm talking about. So sonographically, that's how you see testicular torsion, no blood flow. You compare with the contralateral side. See the contralateral side there. So the contralateral side appear very normal and it's not as enlarged as this, and you can't see this echogenic area there, which is part of the epididymis and the spermatic cord. So you can see intratesticular perfusion, which we didn't see on the other side. So guys, when you are at your department and then there's a request form for a testicular ultrasound, please, you must please attend these patients as quickly as possible. We let it be the problem of the patient who delayed to come to the department than for you to exacerbate the problem. You delay the patient or you rebook the patient, and when the patient comes, it will be too late, and then the test could be dead. So we need to preserve generations. We need people who respect reproduction. So imagine this young boy loses the other testicle again. It means that that boy is infertile for the rest of his life. So let's preserve testicles. Let's prioritize testicles as well. It's one of those emergencies that even if it is during the night when you're told that someone is suspected of having a testicular torsion, you must sacrifice to leave whatever you're doing, even if you are watching your favorite sport. Just try by any means to come and or to go and help a patient with a case of suspected um, testicular torsion. Even ovarian torsion, again, it needs to be prioritized. Ladies and gentlemen, I thank you so much for your time. So this is part of our small part series. So you must be checking out as we send more cases time and again, so that we learn different pathologies. We become better and better as we learn different pathologies. Don't forget to share this educational content and also subscribe to our channel. If you've got any questions, feel free to ask. If you have got any assistance that you need, please do so. At times I might be overwhelmed, but I will always respond. So just be patient, because I attend to a lot of patients. I attend to a lot of people who need assistance as well. But you're always within reach. Thank you so much. Hello everyone and welcome. My name is Last. So in this presentation, I want to show you something. Most of you have been doing abdominal scans for quite some time, but I want you to appreciate one thing. Some of the machines that you're using, we don't really see the movement of bowel. So I want to show you how bowel movement looks like on ultrasound. So you can see here, this is the bowel, so you can see the bowel movement. So the bowel movement. So it is very critical that you must understand or also appreciate normal bowel movement and abnormal bowel movement, because some conditions can cause hypermotility or obstructions. They can cause reduced bowel movement or no bowel movement, aperistaltic segments. The meconium ileus can also cause accumulation of bowel and fetuses and all that. So you must understand or appreciate bowel movement at different stages. So if you also appreciate bowel movement, you can also pick conditions like volvulus, conditions like intussusception. So here you can see here the stomach there, and you can see the bowel movement there, bowel movement there. You can see what is going on. So this is the internal milieu. This is the inside of a 14-year-old girl, and then they were suspecting intussusception. But you can see that there's nice bowel movement there. There's nice bowel movement there. Look at that. Look at that. So this is a nice bowel movement, nice bowel movement. You must also be checking for bowel gas. I will show you how bowel gas appear, like it will having what are called reverberation artifacts. Then you will also have to check for obvious masses that can present if you are doing an abdominal scan. It's not so easy to do an abdominal scan because of the contents of the bowel like that. So you can't really see the outline of the bowels nicely, so you can miss conditions like diverticulums. You can miss those ones. But if there's inflammation, you can see the thickening of bowel. But in this case, this is normal. You can pick enteritis, you can pick colitis, you can pick all those. But in this case, I just need you to appreciate normal bowel movement. Then if you can pick it up from there, it will be easier for you to pick other pathological entities. Even appendicitis, you can pick it. So this is a bladder there, so you can see how the intestines are moving, how the intestines are moving like that. So the problem of bowel ultrasound is most people, they don't have machines which are so good, so it is very easy for you to miss bowel pathologies. So you need a high-end machine that can actually see nicely the whole spectrum of the bowels. And also you have to check for free fluid around the bowels in the peritoneum. So conditions like peritonitis, small bowel obstruction can also cause accumulation of free fluid in the bowel. Even other conditions like renal pathologies, liver pathologies, cardiac pathologies, cancers can also cause free fluid collection in the peritoneum. Even ruptured ectopic pregnancies can also cause accumulation of free fluid. So you must be able to distinguish what is inside the intestines and what is extra intestinal, so that you can comment on the free fluid in the peritoneal space. But in this case, on this window where we are seeing there's no extra intestinal free fluid, meaning to say that everything looks fine. Everything looks fine. There's no sign of obstruction. The walls of the intestines, they are not edematous, so there's no sign of colitis. So I think we are good here. Thank you so much. Hello everyone and welcome. My name is Last. So in this presentation, I want to show you something. Most of you have been doing abdominal scans for quite some time, but I want you to appreciate one thing. Some of the machines that you're using, we don't really see the movement of bowel. So I want to show you how bowel movement looks like on ultrasound. So you can see here, this is the bowel, so you can see the bowel movement. So the bowel movement. So it is very critical that you must understand or also appreciate normal bowel movement and abnormal bowel movement, because some conditions can cause hypermotility or obstructions. They can cause reduced bowel movement or no bowel movement, aperistaltic segments. The meconium ileus can also cause accumulation of bowel and fetuses and all that. So you must understand or appreciate bowel movement at different stages. So if you also appreciate bowel movement, you can also pick conditions like volvulus, conditions like intussusception. So here you can see here the stomach there, and you can see the bowel movement there, bowel movement there. You can see what is going on. So this is the internal milieu. This is the inside of a 14-year-old girl, and then they were suspecting intussusception. but you can see that there's nice bowel movement there, there's nice bowel movement there. Look at that, look at that. So this is a nice bowel movement, nice bowel movement. You must also be checking for bowel gas. I will show you how bowel gas appear, like it will have what are called reverberation artifacts. Then you will also have to check for obvious masses that can present if you are doing an abdominal scan. It's not so easy to do an abdominal scan because of the contents of the bowel like that. So you can't really see the outline of the bowels nicely. So you can miss conditions like diverticulums. You can miss those ones. But if there's inflammation, you can see the thickening of bowel. But in this case, this is normal. You can pick enteritis. You can pick colitis. You can pick all those. But in this case, I just need you to appreciate normal bowel movement. Then if you can pick it up from there, it will be easier for you to pick other pathological entities. Even appendicitis, you can pick it. So this is a bladder there, so you can see how the intestines are moving, how the intestines are moving like that. So the problem of bowel ultrasound is most people, they don't have machines which are so good, so it is very easy for you to miss bowel pathologies. So you need a high-end machine that can actually see nicely the whole spectrum of the bowels. And also you have to check for free fluid around the bowels in the peritoneum. So conditions like peritonitis, small bowel obstruction can also cause accumulation of free fluid in the bowel. Even other conditions like renal pathology, pathologies, liver pathologies, cardiac pathologies, cancers can also cause free fluid collection in the peritoneum. Even ruptured ectopic pregnancies can also cause accumulation of free fluid. So you must be able to distinguish what is inside the intestines and what is extra intestinal, so that you can comment on the free fluid in the peritoneal space. But in this case, on this window where we are seeing there's no extra intestinal free fluid, meaning to say that everything looks fine. Everything looks fine. There's no sign of obstruction. The walls of the intestines, they are not edematous, so there's no sign of colitis. So I think we are good here. Thank you so much.
Welcome, colleagues and friends, in this first trimester Advanced Sunday Life quiz session. So this set covers key advanced first trimester topics, which include ectopic pregnancy, pregnancy failure, abnormal yolk sac, the chorionic bump, cesarean scar pregnancy, interstitial pregnancy, cervical pregnancy, the molar pregnancy, twin chorionicity, knockout translucency, the doctor's venosus Doppler, the nasal bone assessment, physiological mid-gut herniation, placental development. These are specifically ideal for ARDMS, ECOG, a fetal medicine foundation, and the postgraduate ultrasound revision. And all those guys who are also doing ultrasound on a daily basis, they ought to benefit from these quiz sessions. So what I need us to do now, let's go into the quiz session. So I need us to assess the sonographer of the week or someone who is performing better to keep motivating you. So what I need you to do is I need you to write your name, just your name, your first name, and then you give the answers. Just write it once. Then I need you to give the answers as we go. Like now, before I disclose, Once I disclose the answer, you are no longer eligible to give the answer. So now this is question number 1. I need you to write on the comment section your name, then the answer. If it's B, just say Arnold B. Then we do the same question 2, question 3, question 4, question 5, just like that until we reach to question number 20. So we would see who is performing better and where you go wrong. Then we have to discuss about that. So now let's go into our quiz session right away. Don't forget to write your name. You just write once in the comment section in the answer for this. On the next page is the answer. So just give the answer now as I am going through this question. So here we have got a 29-year-old woman presents with pelvic pain and a positive pregnancy test. So these are the ultrasound findings. Empty uterus, then endometrial thickness of 13 millimeters. There's a small right adnexal ring lesion, and there's moderate free fluid. So these are the sonographic findings that we have there. This is the uterus there, and this is the ring that we have there, just like this is the empty uterus. So what is the most likely diagnosis? What is the most likely diagnosis? Let me repeat the question again. A 29-year-old woman presents with pelvic pain and a positive pregnancy test. Ultrasound findings: empty uterus, endometrial thickness 13 millimeters, small right adnexal ring lesion, moderate free fluid. So which is the best option? A complete miscarriage. B, pregnancy of unknown location. C, tubal ectopic pregnancy. D, early intrauterine pregnancy. So which one is the best choice? Now you can give your answer now before I go to the answer. So the next page is the answer. So I'm giving you a few minutes to give the answer. Give your answers, guys. Give your answers there. Give your answers. Give your answers. Because I want to go to the next page. A 29-year-old woman presents pelvic pain and a positive pregnancy test. Ultrasound findings: empty uterus, endometrial thickness 13 millimeters, small right adnexal ring lesion, then moderate free fluid. What is the most likely diagnosis? Complete miscarriage, pregnancy unknown location, tubal ectopic pregnancy, or early intrauterine pregnancy. So now let's go to the answer. I think everyone, we are done now. So you are done now with this question. No more answers. Then you give for the next question. So now the answer is C. This is a tubal ectopic pregnancy. The explanation: tubal ring sign, free fluid, empty uterus, positive pregnancy. These findings are highly suspicious for an ectopic pregnancy. So mark yourself there. Answer is C for number 1. So now let's move on to number 2. So here we have got question 2, the yolk sac mystery. The yolk sac mystery. At 7 weeks, the crown rump length is got 8 millimeters. The yolk sac is got 8 millimeters. What abnormality is demonstrated? So you can see there's the yolk sac there, and then we have got the yolk sac there. Then this is what we have. What abnormality is demonstrated? A, enlarged yolk sac. B, normal yolk sac. C, twin pregnancy. D, molar pregnancy. What abnormality is demonstrated there? This is the yolk sac, the yolk sac, the yolk sac. What abnormality is demonstrated? Crown rump length at 7 weeks. Crown rump length is 8 millimeters. The yolk sac 8 millimeters. What abnormality is demonstrated? A, enlarged yolk sac. B, normal yolk sac. C, twin pregnancy. D, molar pregnancy. Okay, give your answers, guys. Give your answers, because the next page, once I go to the next page, you are no longer supposed to give your answer. It's the time to disclose the answer. So I'll be marking now as we go to see who is performing better. Which is your best choice? Give me your best choice on the comment section. Give me the best choice now. Okay, 1 minute, 1 minute, 1 minute. Let's give the answer. Okay, let's go now to the answer. So our answer is A. Explanation: a yolk sac larger than 6 millimeters abnormal and increase the risks of miscarriage. So answer is A. A yolk sac larger than 6 millimeters abnormal and increases the risk of a miscarriage. Okay, so let's go to number 3. Cardiac activity. So now we have got a crown rump length which is 8 millimeters and there's no cardiac activity. What is the diagnosis? So we've got the fetus there, we've got the fetus there. So if the crown rump length is 8 millimeters with the no cardiac activity this year, what's the diagnosis? A normal pregnancy. B, pregnancy failure. C, ectopic pregnancy. D, twin pregnancy. So which is the best? Give your answer, guys, on the comment section. Is it A? Is it B? Is it C? Is it D? Give your answer. Give your answer. Give your answer now. Give your answer. I'm giving you a few minutes to give your answer. So the current rump length is 8 millimeters. There's no cardiac activity. What's the diagnosis? A, normal pregnancy. B, pregnancy failure. C, ectopic pregnancy. D, twin pregnancy. What is the best option? What is the best option? So I'm going to give you a few seconds so that you finish up this one. Please give your answer. Okay. Now let's go to the answer. The answer is B. The answer is B. That's pregnancy failure. Pregnancy failure. So now let's go to question number 4. The gestational sac. The gestational sac, as you can see there, the mean sac diameter is 25 millimeters. There's no yolk sac. There's no embryo. What's the diagnosis? The mean sac diameter is 25 millimeters. No yolk sac, no embryo. What's the diagnosis? A, normal pregnancy. B, blighted ovum and embryonic pregnancy. C, ectopic pregnancy. D, missed miscarriage. So which is your best option, guys? It's a mean sac diameter is 25 millimeters. There's no yolk sac, no embryo. What is the diagnosis? A, normal pregnancy. B, blighted or unembryonic pregnancy. C, ectopic pregnancy. D, missed miscarriage. Put your answers down, guys. Put your answers down. Now we are, is it A, is it B, is it C, is it D? Put on the comment section. I'm about to disclose the answer now. I am disclosing the answer now. So finish up. Okay. Now let's go to the answer. Our answer is B. That's a blighted ovum. That's a blighted ovum. Answer is B. So there's no fetal pole inside there, inside the gestational sac. So that's a blighted what? Ovum, an embryonic pregnancy. Question number 5. A rounded echogenic protrusion projects into the gestational sac. What is it? A, hematoma. B, chorionic bump. C, a yolk sac. D, a fibroid. A rounded echogenic protrusion projects into the gestational sac. What is it? A hematoma. B, a chorionic bump. C, yolk sac. D, a fibroid. So I'm giving you a few seconds to write your answers on the comment section. Write your answers. Now I am about to go to disclose the answers. What is the correct answer? So now I think we're done. Let's go to the answer. Our answer is B. So the answer is a chorionic bump. It's called a chorionic bump. A chorionic bump. Okay. Question number 6. Which measurement gives the most accurate gestational age during the first trimester? Which measurement gives the most accurate gestational age during the first trimester? A, BPD. B, MSD. C, CRL. D, FL. So which one is the best option there? Give your answers in the comment section. Is it A? Is it B? Is it C? Is it D? Give your answers, please. Don't forget to give your names because we need to choose the sonographer of the week, someone who is doing very well. Which measurement gives the most accurate gestational age during the first trimester? A, BPD. B, MSD. C, CRL. D, FL. So now let me disclose the answer. Answer is C. So it's the crown rump land. So that's the first, the best for the pregnancy dating in the first trimester. Crown rump land. Question number 7. Increased knockout translucency NT is equal to 4.2 millimeters at 12 weeks. Is associated with A. Down syndrome, B. Turner syndrome, C. Congenital heart disease, D. All of the above. So, which one is the best choice? Please put your answers in the comment section. Put your answers in the comment section. Question 7. Increased knockout translucency NT of 4.2 millimeters at 12 weeks is associated with A. Down syndrome, B. Turner syndrome, C. Congenital heart disease, D. All of the above. So the correct answer is D. Is all of the above. All these conditions, they are associated with an increased NT. Question number 8. The hypoechoic crescent adjacent to the gestational sac represents, so you have got the crescent here, this is the crescent there, this is the crescent around the gestational sac, you see the crescent there. What does it represent? A fibroid, B, placenta, C, subchorionic hemorrhage, hematoma, D, placental lake. So give me your answers, please. The hypoechoic crescent adjacent to the gestational sac, this one, the one that we have there, represent what? A, fibroid, B, placenta, C, subchorionic hematoma, D, placental lake. Okay, just a few minutes. Wind up, guys. Wind up, wind up, wind up your answers. Wind up your answers. So now let's go to the answer. Let's disclose the answer. Our answer is C, which is this is a subchorionic hematoma around the gestational sac. It's called a subchorionic hematoma. So now question number 9. So cesarean scar pregnancy. Which feature is more suggestive? Which feature is more suggestive? A sac high in the fundus. B, sac implanted in a previous cesarean scar. C, placenta previa. D, cervical pregnancy. Which feature is highly suggestive of a cesarean scar pregnancy? A sac in the fundus. B, sac implanted in previous cesarean scar. C, placenta previa. D, cervical pregnancy. Which is the best option? Give me your answers. Just type in the correct option before we move to the. Once we move to the answer, you are no longer eligible to write your answer. So, which feature is most suggestive of a cesarean scar pregnancy? A, sac high in the fundus. B, sac implanted in the previous cesarean scar. C, placenta previa. D, cervical pregnancy. So you see, this is the uterus there. So there's a pregnancy here. The pregnancy, which is the best answer. So let's disclose the answer. Our answer is B. Our answer is B. So it's located in the previous scar of the cesarean section. Previous cesarean section scar. So question number 10. Which sonographic sign is classic? You see, this is the uterus there. Then you can see what we have there. What we have there. Which sonographic sign is classic? A, the sliding sign. B, ring of fire. C, interstitial line sign. D, the Whirlpool sign. So we have got the pregnancy there. That's the uterus that we have there. You can see the gestational sac there, and on the color Doppler, that's what you are seeing there. And